you're looking for a video that will help you with maternity before you take your NCLEX, this is the video you want to watch. 100 questions, maternity concept, high yield, straightforward questions and answers with rational test-taking strategy. Stick around, answer the questions on your own, and let's get to it. 100 question. Buckle up. Nurse is caring for a client immediately after amniotomy. Which intervention are indicated and not indicated? This is in the matrix form. It's the same thing you already know. You have the content. Relax. Step back. Look at the question. Take out the table from the question. Pretend it's a select or apply question. When you do that, you have what? A good vision of the question, and all the question is asking you is what? Amniotomy. That's all. And therefore, what do you do? Intervention. Is it indicated or not indicated? Then bring your content and tell yourself, amniotomy means the doctor itself is breaking your water. What should you worry about? The concept is every time you break the water, the placenta may prolapse. If it prolapses, what do you think? And that is the first keyword to answer the question. What do you think? Should you assess for fetal heart rate immediately? Should you monitor for cord prolapse? Should you place the client in the supine position with the leg flat? Do you observe fluid color of the amniotic fluid? Should you delay vaginal exam until 12 hours later? What do you think? This is what the concept is about. Stop the video, fill in the matrix, and I'll give you the answer. But the content I've given you, the amniotic fluid is going to leak out. The cord is going to prolapse. What would you do then? That's the concept. Therefore, the first thing you do, assess for the fetal heart rate, because the cord prolapse will cause for deceleration. And therefore, we have to check for cord prolapse. If there's a cord prolapse, which position do you place the patient? Mean to chest position. Therefore, keeping them supine is the wrong answer. You see how everything is coming together? Of course, you got to observe for the color so that there is no meconium in it. You want to check there's no meconium. If you're going to assess for cord prolapse, there's taking strategy. Why will you delay vaginal exams 12 hours later? You need to check for cord prolapse. And these are critical thinking questions I've designed by putting it in a table form so that you think like the NCLEX. You don't run away from it. So what is the concept you should take away from this? Risks of cord prolapse whenever there is amniotomy. Therefore, assess for fetal heart rate and check the color. Supine position is going to worsen cord prolapse. First question, NCLEX practice question, detailed answer, expect answer, maternity, nursing for your NCLEX and nursing school. Number two, what do you think? Same thing. You already know it. You've seen questions about it. But put it in the table form. Take the table out, unravel it, make it a single standalone question. The table does not mean anything. It means indicated or not indicated. It's just a selected apply. And then provide teaching for a breastfeeding client with what? Mastitis, inflammation of the breast. Sometimes the ductals are blocked. That's why the breasts get bigger and tender. But which teaching are indicated or not indicated? You already know. What do you tell a patient who has mastitis? I give you in the table form. I put it indicated or indicated. It does not mean anything. It's just next generation NCLEX. They just put table around what you know. Therefore, hindsight the way they present it, but assume it's a selected apply. Do you continue what? Breastfeeding in this situation? Do you apply warm compression? Do you wear a tight bra continuously? Increase fluid and rest? Do you stop breastfeeding permanently? The key concept to answer the question, you can stop it, answer it on your own. Then listen to me. 10 seconds. The concept is what? We want to improve breast milk production. Every answer choice that increase breast milk production is your right answer. Therefore, what will your answer? This is my answer. Make sure a mirror image yours. I know you watch adapting quiz, so you're going to get all 5 right. What do? We still have to continue breastfeeding, especially from the side of the breast that has the inflammation, so that milk can flow. We got to improve comfort and improve blood flow, so warm compression is good. Tight bra is not good. It's going to prevent milk production. So don't, you have to wear supportive bra. We got to increase fluid so that we can make more milk. And you should not stop breastfeeding permanently. And the concept is what? No tight bra, no need to stop breastfeeding. Every time you see a mastitis, this is the question they're going to ask you. Next generation NCLEX practice question, maternity nursing in the matrix form. I know you got it. Number 3, which scenarios are indicated for Rhogam? You know it. You know it. Don't worry about the negative, positive. I put it in the table trying to confuse you, but you got it because I know you watch adapting quiz and you know the content. Which situation will you give Rhogam to a patient? That's all. Indicated or not indicated. What is the content? Stop the video, answer these 5 questions, and I know you're going to get 5 out of 5. If you're in nursing school or taking your NCLEX, these concepts you have to know. There is an indication for Rhogam. But what is the major one? The problem is an Rh negative mother giving birth to Rh positive baby. And therefore you have isoimmunization. And that causes problem for the subsequent baby. Therefore, we want to give you Rhogam to prevent isoimmunization. That's all. What is the problem? Rh negative mother give birth to Rh positive baby. Do you think you need a Rhogam? Rh positive mother give birth to Rh negative baby. Do you think you need a Rhogam? If you have miscarriage and you are Rh negative, do you need a Rhogam? If you have ectopic pregnancy and you have Rh negative, do you need it? If you are Rh negative and your husband is also Rh negative, would they give it to you? Answer it. I know you got it. 5 out of 5. I know you're going to get it. But based on the concept, number 1 has to get it because the baby is Rh positive. What about number 2? Number 2, that's not needed because mommy is already Rh positive. Giving birth to Rh negative baby is not a problem. If you are Rh negative, you need it. You get miscarriage, ectopic pregnancy, abortion. So you're going to get it. So both of them are going to get it. If the Rh mother is Rh negative and father is Rh negative, the baby is going to be what? Rh negative. There's no way the baby will be Rh positive. Therefore, that's not needed. And this is the way it's going to look like. I want you to watch this portion of the video multiple times so that when you see a question about this, you're going to master it. And what is the content? No risk of isoimmunization if the mother is what? Rh positive. Rh negative mother and Rh negative father will give birth to Rh negative baby, and therefore no need to worry about it. Number 4, and then it teaches a client with what? Diabetes, gestational diabetes. Which teaching are indicated or not indicated? I have gestational diabetes. What do you tell the mother? The same thing. Stop the video, answer it on your own, and follow this series, and you can see by the end of it, you're going to master maternity. Mother blood glucose regularly, right? You're going to monitor blood glucose regularly. Should you do that? Should you follow a diet with what? Consistent carbs? Are you going to teach the mother like that? Tell her that oral hypoglycemic at the first line, that she's going to take metformin by mouth. Report persistent hyperglycemia. When she has these symptoms, she should report it. That insulin may be prescribed. What do you think? Gestational diabetes. Yes, of course. If you have diabetes, we have to monitor your glucose. We also have to teach you about carbohydrate, right? Oral hypoglycemic drugs can cross the placenta and can give problem to the baby. So we don't want that. You have to report any persistent hyperglycemia. That's an issue. And the first line is usually insulin. So this is the content you have to teach them, parents and the mother. So oral hypoglycemic, you shouldn't forget, it crosses the brain blood, crosses the placenta. So you have to be careful about it. Number 5, and then prepare care for a client with severe preeclampsia. Patient has what? Severe preeclampsia. What are you going to do? What kind of precaution are you going to do? Which teaching are indicated or not indicated? You've seen questions like that. This is just in the table. Just pick each answer choice. Don't compare them. See them as isolated situation related to the concept. The concept of what? Severe preeclampsia. What do you want to do? That's all. You want to prevent eclampsia. Patients should not have seizure. Therefore, number 1, administer magnesium sulfate. Do you think it's inappropriate? Keep quiet on strict bed rest. Do you think it's appropriate in a patient with the severe preeclampsia? Do you think you should keep them in bed? Do you think you should encourage sodium diet, high sodium diet? Should you monitor their urine output? And if there's a Pitocin prescribed, should you give it to the patient if it's prescribed, because to induce labor if prescribed? What do you think? Of course, magnesium is indicated. We don't want the mother to have seizures, so stay in bed. Sodium is going to increase your blood pressure, so that's not good. We're going to monitor your urine output, including your reflexes and everything, if you're getting magnesium. And of course, delivery is the best way to prevent this problem. Therefore, if it is prescribed and is indicated, I'm going to give it to the mother. So this is the key aspect you got to pay attention to. High sodium diet is going to worsen your hypertension and edema, so we don't give it to you. No, low sodium diet. Question 6, let's get to it. I know you warm up. Now let's get to this. And next, assist with delivery complicated by what? Shoulder dystocia. Which intervention are indicated or not indicated? The concept is what? Underline it. Don't worry. You know the thing. Shoulder dystocia. You know the problem. Ask yourself, what is the problem? Baby, it's not coming out because his shoulder is locked in place due to probably the pelvis is too small or due to presentation. How do you relieve the baby from shoulder dystocia? That's all. That's the intervention. Do you encourage knee to chest position? Apply fundal pressure. Apply suprapubic pressure. Notify the neonatal team, or tell the mother to continue to pull you pulling the fetal head forcefully. Would you do that? What are the intervention? All these questions, 10 questions, I take it maternity concept, maternal health concept, and then I indicated what intervention, expected finding, what you need to do. That's what the NCLEX will ask you. If you know all this information, every time you see a question, go back to that content. That's the way you learn. Take the concept, find the intervention, find the complication, find the expected finding, and create a table and memorize them every time they're going to ask you the same question. That's what I've asked you. Shoulder dystocia. What do you do? Of course, Mark Roberts maneuver, knee to chest position. You should not apply fundal pressure because that's a trap, but you should apply suprapubic pressure. And the baby may need to be resuscitated. If you pull the head too hard and forceful, you're going to cause breakthrough-presses. That's nerve injury, and therefore you should not do that because the shoulder is locked in place. So don't do that. And therefore, the key concept is what? No fundal pressure. That's the key. Forceful pulling of the K will cause what? Nerve injury, called breakthrough-presses. You can see we cut it. This question, this table, this particular image, you can use it to answer any question, even in the case study. If they give you shoulder dystocia, if it's not on this board, then let me know. And then assessing a postpartum client on day 3. Patient just had a baby. Day 3, you should expect what? Which intervention require intervention or no intervention. The concept here is after you deliver, The uterus supposed to go down. How much does it go down? Every day, 1 centimeter. Therefore, 3 days, it should be below the umbilicus. Which one I've given you require you to intervene? Don't make the question so difficult. It's straightforward, but it's presented in the table form with some confusion. I'm breaking down the question, test-taking strategy, adapt and close way, how to answer question. Break the question into pieces. 3 days postpartum, uterus is supposed to come down. I've given you some bunch of stuff on the left side. Look at it and analyze each of them. If the uterus is firm and is 3 centimeters and below the umbilicus, what do you think? This is the individual, and the umbilicus is here, and the uterus is here. It's firm and it's below. The uterus is still in the midline. Here, uterus is boggy and displaced to the right. It's going to the right side. We have Lochia still present. The uterus is above the umbilicus. Which situation you need to intervene? They said require intervention. If you're going down 3 centimeters below the umbilicus and it's after 3 days, you are good. I don't need intervention. If you're in the middle, uterus in the middle, I don't need intervention. But if you're boggy and you displaced, I got to do something about you. Otherwise, we're going to bleed. Lochia is going to be present, rubra. Lochia, rubra will be present 3 to 4 days. That's okay. I don't need to do anything. And if you're above the umbilicus, we got to intervene. Otherwise, you're bleeding. This number 7 question, if you have questioned about it, watch it multiple times. Put it in the comments. Let me know which one is disturbing you, and I will explain it to you. But you got to understand number 7. A uterus should be firm, contracted, and below the umbilicus. Lochia present 3 to 4 days. Rubra is going to be present. Number 8. And NS cares for a client admitted with what? Hyperemesis gravidarum. Like I said, concept associated with OB, maternity, maternal ed. And then I create select all apply, but I put it in the table form. It becomes a matrix. And then they ask you indicated, not indicated. You already know it. There's nothing like next generation. It's the content you know, and they put it together. Therefore, if you're vomiting, you have hyperemesis gravidarum, you think we should give you fluid. Of course. Do you think we should give you something for your nausea? Yes. Do you think we should give you small frequent meal? Yeah, like somebody who have a reflux. That's what we do. Do you think we should stop fluid until your vomiting stop? No, you're going to get dehydrated. And do you think we need to monitor your electrolytes? Of course, we should do that. And that's that question. IV fluid, oral fluid is needed to prevent dehydration. Therefore, this is the way the table is going to be. 8 questions. What are your points? 8 out of 10? I know you get 8 out of 10. If there's one disturbing you, go back and look at it. But it's the content you already know. But this is what they have to ask you. They will ask you this in a case study, in a standalone, and GN-style form, in a matrix. You got this. Let's get to it. 2 more questions, and let's ace this. And this is caring for a client with what? Placenta previa. You have to know what is the placenta previa. It means the cervical os is being covered by the placenta. Major risks associated with this, bleeding. Therefore, everything you do prevent bleeding. Which intervention is indicated or not indicated? 1, say bed rest with bathroom privileges. Is that what you want to do? Avoid vaginal exams. Is that what you want to do? Continue fetal monitoring. Is that what you want to do? Should you prepare for C-section if the bleeding is so severe? Should you encourage the mother to walk every 2 hours so that they don't get DVT? What do you think? Test-taking strategy, adapting class, maternity, NCLEX practice question, high yield, critical thinking, matrix form, next generation questions. Number 9, we're talking about placenta previa. You know it. You know what? I give you the content. I'm preventing bleeding. Therefore, well, if you walk, you're going to bleed. Therefore, don't walk. This placenta is covering the cervical os. If I put my finger there, there's going to be bleeding. No. Therefore, I'm not going to do that. So avoid vaginal exams. Now, baby is going to be in trouble, so I need to monitor the baby. If the bleeding is too severe, well, we got to have C-section. If mommy walk, there's going to be more bleeding. Therefore, no bleeding, no walking. And that's the content regarding this question. So bed rest, no ambulation every 2 to 2 hours because you're going to bleed. And the last one, for the road. Of course, you know it's coming. Magnesium is something you have to know for OB maternity. And that is what concept I'm giving you here. And then administers magnesium sulfate IV. What do you do when you give a patient with magnesium sulfate? Which intervention, which finding require immediate intervention? They can ask you in the standalone, in the case form. I'll give you in the selected apply, but I put the matrix form on it. So you know you got to understand it. You got it. Respiratory rate of 10. Reflexes is absent. Urine output is 50. Serum magnesium is 7.4. Patient is reporting flushing and M1. If I give you magnesium, it means I'm increasing your magnesium. High level of magnesium would depress your nervous system. Therefore, I expect your respiratory rate to go down. I expect what? Your reflexes to go down. But these numbers are going too low. Respiratory rate of less than 12 is a problem. No reflexes is also a problem. I expect them to go down, like 1 or 2 is fine. 1 is fine. But if you've gone down and it's no more present, it's a problem. Respiratory rate is supposed to go down. But if you go below 12, we got to intervene. Your urine output is going to go down. But if you pee in 50 ml per hour, you're good. Magnesium maximum level is 7. 7.5 is toxic, right? I got to intervene. And if you complain about flushing, it's an expected finding when you're having magnesium. What is the nurse priority assessment following the procedure? A nurse is caring for a client who is in what? Active labor and has just undergone an amniotomy. Test taking strategy. In every question, we'll be talking about test taking strategy. What do? Don't even look at the answer choice. Figure out what is going on with the question. They said a nurse is caring for a client who is in what? Active labor and just had what? Amniotomy. What is the problem? Amniotomy is if you cannot spontaneously rupture your memory, the doctor will do it for you. So the doctor basically broke your water, broke the memory, and the amniotic fluid came out. What is your next priority action? This is the same as somebody who has spontaneous rupture of memory. What do you think should be your priority in this situation? Remember, the amniotic fluid surrounds the baby floats in it. Whenever amniotic fluid comes out, there's one thing you should do. You should check for what? That's the answer choice. That's the key concept. That's the concept you have to use to answer the question. Therefore, what? Assess for client pain level, monitor maternal vital signs, check the fetal heart rate, evaluate the color of the amniotic fluid. The concept here is what? Every time you see amniotic fluid comes out or there's somebody's water broke, there's a risk of loss of amniotic fluid. In the process, you're going to have what? Cord prolapse. So whenever there's a rupture of the memory, look for cord prolapse. If there is a cord prolapse, baby is going to show signs of what? Bradycardia, which is what? Deceleration. Therefore, what do you need to check? You know the answer, popping out like a candy based on the concept you have used. Therefore, assessing the client's pain, they're not supposed to have too much pain. They just have small discomfort, but no pain. Of course, we're going to monitor their vitals, but that is the most important. The most important, the one who is going to suffer is the kid. Of course, I got to look at the color of the amniotic fluid. If it look green, and if there's what meconium in it. But I have to look for number one is called prolapse. Therefore, first question down, and the answer choice is what? Number three. Priority assessment after amniotic fluid amniotomy is what? Fetal heart rate assessment to determine what or detect umbilical cord prolapse or fetal distress. Therefore, three is the best answer. We're going to use the same strategy. Each question we've got to talk about concept and use critical thinking to find the answer choice in this maternity nursing NCLEX review practice test number 5. Number 2, during a prenatal class for what? Gravidarum. That means first pregnancy. A client at 38 weeks asks when she should go to the hospital. What is the question is asking? When is the first time to go to the hospital to know if you're in labor so that you can go deliver if this is your first pregnancy? Which response by the nurse is the most appropriate? Same thing. Underline the buzzword. The buzzword is most appropriate. 38 weeks. When can I go to the hospital? That's all. What do you think? Think about it. When contraction occurs like a true labor, when contractions are irregular and mild, when you feel the baby move less, when your memory rupture, and if you are not contracting, even if you're not contracting, think about, look at each answer choice. Stop the video, put down your answer. Let me know. You got it. You can use the information we talk about in first question to answer this question. What are you going to tell a patient who asks you, when am I ready to come to the hospital? Because probably I'm going to deliver. This is a first pregnancy. The key, the buzzword, the concept is what? If you have regular contraction or if you rupture your memory. If you rupture your memory, there's going to be what? Risk for cord prolapse and infection. You need somebody to check it. Secondly, we got to make sure you are in true labor, but you don't know it. You can't tell a patient that you are in true labor. She has no clue the definition of true labor. These words belong to the nurse and the doctors. She doesn't know that. What she will know is when the contraction is regular. But this one say irregular. So if you have been contraction every 5 minutes within an hour, then you are in what? True labor. You should come to the hospital. Feeling the baby move less is not evidence of labor to come to the hospital. Therefore, the right answer is if your memory rupture, even if you're not contracting, because of the risks of what? Cord prolapse and infection, you should come to the hospital. Therefore, number 4 is the right answer. And that is the concept for this particular question. Clients should come to the hospital when contractions are regular every 5 minutes for the first hour, right? That is the key because it's a regular contraction. And if memory rupture due to the risk of infection and cord prolapse, therefore, is the right answer, is the best answer, and is the most appropriate response from the nurse. During labor and delivery, the nurse performs Leopold maneuver. This is a concept. These videos are concept. Like I said, if you don't know them, write them down. But I'm going to make a bunch of them. This is number 5. It's a concept you need to know. And they are easy information you see in the question. When you know it, answer pop up like a candy. All you need to know, what is Leopold maneuver? At this stage, you should understand what is Leopold maneuver. If you don't know, this is the concept. The purpose of this assessment is to what? Cervical dilation and effacement. Determine fetal position and presentation. Assess maternal pelvic adequacy. Estimate fetal weight based on what? Fundal height. Leopold maneuver. Look at the answer choice. Some of them does not make sense. When you evaluate cervical dilation effacement, you don't do any maneuver. You just use your finger, examine, and then do a vaginal exam. That's all. But to determine fetal position and presentation, it looks like you got to do some maneuver to be able to know where the baby is. I'm using test-taking strategy, critical thinking. Assess maternal pelvic adequacy. It's a pelvic exams, right? Estimate fetal weight based on fundal height. Well, you got to weigh the mommy, right? And you got to weigh, you have to do a bunch of subtraction. I don't think there is going to be any maneuver. You know the pregnancy weight, and then you weigh the mommy, what is the weight right now. You can subtract it, and you can figure out the difference, what the baby is giving to the mommy. Therefore, Leopold is designed to check for position and presentation. They are used to palpate the abdomen to determine the fetal lie, right? Their position and presentation before and during labor, so that we know where the baby head is and everything, so that we can rotate them into a vertex position. Therefore, normal 2 is the right answer. You see how you approach question, test-taking strategy. This is how you master them. And next is monitoring a client in active labor, right? The fetal heart rate decreased to what? 80 beats per minute during contraction. What is the next first action? Prioritization 101. You got to be sharp. Is there breathing, electrolyte shock, sepsis, airway, a neurological problem? Of course, yes. Bradycardia. What do you think? The baby has bradycardia. That is deceleration. Bad problem. This shows that's the placenta problem or blood flow problem. You don't know. Do you document the finding? Baby has bradycardia. Do you reposition the client? It can be any position, left lateral or knee to chest. Increase the IV pitocin. It's going to cause more contraction. Baby heart rate drop with contraction. Therefore, do you want to do that? Notify the provider immediately. Can you do something else before you call the doctor? Test-taking strategy. I know you know it. Adapt and close way. What do you think? This baby is not doing well. The best thing is to ensure blood flow, whether knee to chest or left lateral position, do it. But the most important is mostly uterine placenta deficiency. Therefore, what is the problem? We need to place mommy on the left lateral position. This will allow blood flow and the baby will do fine. So the first action is changing position, mostly on the left side. That's the right answer. Number 5, when a fetus is in the vertex position, the nurse should listen for the fetal heart tone at which location. Like I said, this maternity series is about concept. Well, you got to write this down. How can I find the baby position if they're presenting in the vertex position, or if they're presenting in what? Bridge position. These concepts, you have to know it. And this is one of them, how to answer that. And this question answered that question. Baby is in vertex. That means this is the mother, baby, and umbilicus is here. Baby head is here, like that. The baby head has to be down. Baby may be laying down. It can be any position. So far as it's like that, baby head is way down here, like that. Therefore, it's 99% below the umbilicus. The baby can lay down like that and still will be what? Below the umbilicus. If the baby is breached, that means his head will be on top like that. It's above the umbilicus. So the concept is, in vertex position, the head of the baby is below the umbilicus. Therefore, if the head is below the umbilicus, this is the baby head, I can listen to the heart sound here or here. Therefore, not above the umbilicus, in the upper right upper quadrant of the abdomen. That will require what? A transverse lay, right? Below the mother's umbilicus, yes, it's below it. It can be left or right. Midline and the fundus, you don't check it. So the best position is usually either left or right and below the umbilicus, because the baby is in the vertex position. With the vertex position, the fetal heart tone are best set in the lower quadrant of the maternal abdomen. So 3 is the right answer. Which response is most appropriate? This question can be hard. It's not hard. It's based on language, words the NCLEX will put on, and certain words you should avoid when you're picking an answer choice. That is the strategy here and the concept. A client with what? Type 1 diabetes. Boom, ask the OB nurse which method of contraception is best. She has diabetes and she want to know which method of contraception is best. The key word is what? Diabetes. What do you know about diabetes patient? And she want to know which contraception is best. The concept here is what? Stop the video. I want you to try this question. And then when you finished, begin listening to me. 10 seconds. I know you got it. Did you put down the answer? Yeah, you got it. I know the answer you choose because you watch adapting. What is the right answer? And what is the concept? Diabetes patients are most likely to get cardiovascular complication. They have cardiovascular complication already. Therefore, you should not give them any contraception that will cause more cardiovascular complication, like any hormonal medication that contain estrogen. And that is all the key word to use. Therefore, IUD is okay, but look at it. This is the buzzword. Safest. Never pick an answer choice in the NCLEX that is totally 100% talking about the best, right? Safest method. Barrier method, yeah, is good. It is not hormonal, but he said it's the best choice where there's other choices. Hormonal method, yes, we should avoid it. And what do you say? Increase your risk of what? Vascular complication. Sterilization is the, look at the word, only safe method for you. So which one would you choose? Which one would you choose? This is number 6. It's a little bit difficult, but that's what it's designed. But I'm trying to teach you certain things when you're picking an answer choice. There's taking strategy. IUD is good, but it's not the safest. The word safest changes the answer choice. It's too absolute. Barrier method, you put the word best. It's too absolute. Hormonal method, yeah, it increases the risk of vascular complication. It does not say anything, it's just telling you the fact. Sterilization is not the only safest method. And therefore, the right answer is number 3. But that's the concept I want you to know when you're picking an answer choice. Clients with diabetes are at increased risk of what? Cardiovascular and vascular complication. Therefore, barrier method and IUD are preferred, but none of them is the best, right? None of them is the safest. They are okay, 100% the same. Second one, too, is this. When you're picking an answer choice in the NCLEX regarding oral contraception, always think about estrogen. They're more likely to cause clots. Therefore, safer method is to use progesterone only one, or barrier method, or IUD. You should not pick an answer choice that's the safest, the only safe method, the best. No, that one make it wrong. 7, this is also content. It was in the previous video, but I expanded. In which situation would administration of Rhogam be indicated? You have to know situation when we give Rhogam. Select or apply. At 28 weeks of pregnancy with what? Rh negative mother. After delivery of what? Rh positive baby. After amniocentesis. When the mother is Rh positive and give birth to Rh negative. After abdominal trauma during pregnancy. If you're confusing, don't worry. Ignore it. Ignore the answers. Go to your content. Take your content. It said administration, Rhogam, the safest, indication. What is the problem? It happened when mommy is what? Rh negative. And he gave birth to what? Rh positive. Right? So that's the key information. If you don't know anything at all, mommy give birth to Rh negative and the baby is Rh positive. That means the mommy will be what? Synthesized with that problem. Therefore, we got to protect the mommy. And therefore, if you are Rh negative at 28 weeks, we don't want you to get antibodies, so we give it to you. It's given at 28 weeks. If you deliver Rh positive baby, we have to give it to you. If you have amniocentesis, we are exposing the baby blood onto you. we're going to give it to you as a precaution. When you are Rh positive, I don't worry about you anymore. It does not matter whether your baby is Rh negative or positive, because you're already Rh positive, I'm good. And you involve in accident, you're going to get it. So those are the situations I want you to know. Indication for Rhogam. Rhogam is indicated for any situation where there's blood mixing that occur between the mother and the baby, where the mother has what? Rh negative, right? And not indicated if the mommy is Rh positive. So that's the key. So 1 is right, 3 is right, 5 is right, and then 2 is right. 4 is wrong. Which finding will require the nurse to intervene? This is another concept. What is the concept? A nurse is assessing the postpartum client 3 days after delivery. Which finding will require the nurse to intervene? And you can see the answer. She's talking about the uterus. After delivery, the uterus is supposed to go down. It goes down, what? 1 centimeter every day. So if this is the umbilicus, after delivery, the uterus is slightly above the umbilicus. By 12 hours, it's supposed to keep on going down. It goes down 1 centimeter every day, 1 centimeter every day. It keep on going down 1 centimeter. So after 3 days, it should have gone down 3 centimeter below the what? The umbilicus. And that's your right answer. Uterus is located 3 centimeter below the umbilicus. You don't need to what? Intervene. Uterus is firm and midline. You don't need to intervene. We want it to be contracted and in the middle. If it's boggy and it displays, we have a problem. Uterus is palpated above the umbilicus. 3 days, you stay boggy. If you're above the umbilicus, you're going to bleed. Uterus descend 1 centimeter per day. That is the requirement. Therefore, which one require intervention? What do you think? Number 3. You see the strategy. That's the concept I'm using to answer the question. Day 3, postpartum, the uterus should be involuting and descending. The fundus above the umbilicus may indicate uterine atony and retain fragment requiring intervention. This is the content. Like, I answer the question and I give you the content associated with it. That is why it's maternity nursing, NCLEX review, NCLEX practice question, test taking strategy using expert review to answer this question. And you take note regarding this information. Number 9, a client at 6 weeks gestation is taking levothyroxine. Which station should the nurse provide? What is the content here? If you have hypothyroid and you're taking Centroid or levothyroxine and you're pregnant, you got to teach the patient. Don't stop the medication. Continue taking the medication. You may probably need a double dose, but you should not do it on your own until the doctor tells you to do that because of the immunosuppression. But you have to give them information about safe medication administration. You should stop taking this medication after pregnancy. No, it's going to get worse. Take the medication on empty stomach, separate from your prenatal vitamins. Yeah, you should take it with a full glass of water and remain upright for 30 minutes. This medication is unsafe in pregnancy and should be changed. It's safe in pregnancy. You can still take it. You should double the dose during pregnancy for best results. You should not double the dose in certain situation. If you get sick, yeah, but the doctor is in charge. What you need to do, take the medication on an empty stomach, separate from your vitamins. That's the concept. Levothyroxine is safe, necessary during pregnancy. It should be taken on empty stomach and separate from what? Any vitamins that you take. No iron, no calcium supplement, right? And the last question. A client who is 12 weeks pregnant is newly diagnosed with grave disease, hyperthyroidism. Which treatment is indicated? This is pharmacology. I want you to know endocrine pharmacology in addition to maternal pharmacology in the patient who is pregnant and is diagnosed with what? Grave disease. But this question requires critical thinking. I want you to try it and think about the answer and put down in your answer and let me know what you think. Then listen to me. It's a test-taking strategy. A client who is 12 weeks pregnant is newly diagnosed with grave disease. Which treatment is indicated? Levothyroxine, radioactive iodine therapy, PTU, and methimazole. Stop the video, answer it, and let me know what you pick. The content is what? Grave disease, you have too much thyroid hormone. We got to slow you down. Which medication you're going to use? Number one, think about it. Levothyroxine is thyroid hormone. Patient already have too much thyroid hormone. Why do you want to give them another thyroid hormone? Wrong answer. Patient is pregnant. They cannot take any radioactive iodine therapy because they're pregnant. Therefore, you're left with 3 and 4. This is the content, endocrine content. You have to know this because if you see a question and they give you a pregnant lady, you have to be careful. In the first trimester, PTU, proprietary uracil, is the one that is best, that put the thyroid hormone down, that you can use for grave disease. After the first trimester, methimazole is the safest. Both of them can be used to treat hypothyroidism, but PTU is the best in the first trimester. And after that trimester, second, third trimester, you can use methimazole. What am I trying to teach you? APGAR score, you have to know how to calculate it. You got to be familiar. They are straightforward, but you have to know the component, right? APGAR, APGA, with the A is your appearance, and the P is your pulse. G is your grimace, right? A is your activity. R is your respiratory rate. But what is the question am I asking? Which grimace? This is the one always trick people. You easy to make a mistake about it. They don't tell you it's a reflex, but it's actually a reflex response will receive a score of 2. In the APGAR score, you get 0, or you get 1, or you get 2, a total of 10. That is the key. Which of these grimaces signs will give the individual what? 2, showing good reflex. Look at it. If you coughing, yeah, your glossopharyngeal, they're doing their job. If you wimpy, no way. Facial grimace, that means you're not moving that much. If you're sneezing, that require a lot of multiple cranial nerve with good reflexes. Crying, same thing. No response, of course, you get 0. But these are key facts they will put in a question, and I'm giving it to you. Pay attention, write about them. Grimaces, these are the easy one. The other one too is activity. That can also be tricky. Therefore, the content, what? You get 0 if you have no response. 1 if you have minimal response or you whimpering. Or you have grimace, but it's just a facial grimace, only 1. You get 2 if you're very vigorous, you're coughing, you're sneezing, and you have a strong cry. Therefore, what do you think are the answer? Sneezing, get 1 point, 2 points. Crying, get 2 points. And cough, get 2 points. These are little things you have to know. I suggest you write them down. Question number 1, answered. NCLEX practice question, maternity NCLEX review. Next one. What am I trying to tell you? Concept. Like I said, every question has its own concept. What is the concept? Why do we give Rhogam? Because you have to teach the patient. What do you think? And what is the content? In another series, I will give you the indication for Rhogam, which client statement indicate correct understanding. A postpartum client receive education about Rhogam. What do you think? I receive Rhogam because what? So my baby's blood type won't be affected. Is that the reason why? I receive Rhogam to prevent my body from making antibodies against my baby's blood. Rhogam will cure me if I already had antibodies. I only need Rhogam if I have a miscarriage. These answers are all content-based. And like I said, these are straightforward but require some thinking. When do you give Rhogam? There is a concept associated with it. You usually give it either at 28 weeks or 72 hours after delivery. There's some situations where you have to give it. Either you have other conditions, right? Miscarriage, abortion, ectopic pregnancy, even if involving trauma, involving molar pregnancy. If they do an invasive procedure, like I said, I will set a question regarding that concept. But this is what the mother is saying. Put down your answer. Let me know what you think. Which answer choice do you think is the right one? Based on the content, what are we doing? We are preventing sensitization of the mother. That is the key. I only need it, only make you not to pick this answer choice. Miscarriage, you need it for more than that. If you have abortion, if you have a trauma, you have miscarriage, you will need Rhogam. It does not cure any antibodies that are already there. It cannot deal with it. We want to prevent you from making antibodies. The already antibodies that is already there, it cannot cure it. You're receiving the Rhogam to prevent, it's a prevention, sensitization of you making more antibodies. My body for making antibody. That sound more reasonable. It indicates what? Correct understanding. I receive Rhogam, so my baby's blood type won't be affected. It has nothing to do with your baby, it's you. The baby blood is going to be the same, but we don't want you to react with the baby's blood. Therefore, number 2 is your right answer. But this, I'm breaking down the question, show you test-taking strategy how to answer questions. Take your time, go for the keywords, the buzzword in the question, and break it down. Rhogam prevent maternal what? Sensitization to Rh positive fetal blood, preventing hemolytic disease in the future pregnancy. Therefore, number 2 is the right answer. Which statement by the client indicate further teaching is needed. Once again, stop the video, answer the question, then look at the way I'm going to approach it and master the style that I use to answer question. I want you to do that because it makes question answering easy. I read it from the back. And what did I do? I go for the buzzword, which statement by the client indicate what? Further teaching. I'm dealing with the further teaching. They're saying something bad. They're saying something wrong. Therefore, a postpartum client report what? Redness, buzzword, warmth, buzzword, tenderness, buzzword, where on the breast. A collection of these buzzwords tell me mommy has mastitis. Then bring your content. How do you answer questions on mastitis? Know your content regarding that. And based on what your content say, if they say something contradictory to what you know, you're going to think that need further intervention or teaching. As you continue breastfeeding or pumping from the affected what? Breast. That means he said, keep on feeding the baby through that affected breast. I can take what? Warm compression to relieve what? Discomfort. What is she saying? Warm compression will release comfort. Number 3 said, I will stop breastfeeding until the infection has gone away. Number 4 said, report any fever or flu-like symptoms to the provider. The key is when you have mastitis. The concept is when you have mastitis. The maternity concept when you have mastitis is to keep on allowing breast flow, which answer choice improving breast flow. Number 1 said, keep on pumping and breastfeeding. You are allowing breast flow. Number 2, using warm compression will allow breast milk flow. 3 said, don't allow it. Stop it completely until the infection goes away. Infections never goes away if it's not coming out. And 4 said, if there's a signs of deep infection, fever, flu-like symptoms, I should let my doctor know. What do you think? Which one is a bad sign? You need to intervene. Mastitis is not the contraindication to breastfeeding. Continue to nurse or pump a plate infection. Therefore, saying that I will stop breastfeeding until the infection completely resolves need further teaching. Number 4, what is this question about? It's a straightforward. I don't want you to overthink it. You look at the answer choices, said they look the same. What am I trying to teach you? NCLEX will set questions like that. Like I said, every question in your test has a concept they want to test. A client with preterm labor is prescribed what? Beta methazone, right? Steroid. Which order should the next question? That means they want you to know what is the steroid and what is being prescribed that you need to question. All of them said administer something, and then there's different doses, and then there's the IM, and then there's the IV. There's different times and different dose. They don't want you to know the dose, the frequency is irrelevant. The key is you can see the difference is the route. Of course, you have to know the route of this medication because it's an emergency medication used in what? In preterm labor, that we got to give it to the patient as soon as possible. Therefore, what do you think? I see 3 IMs and I see IV. That is your clue. There's an odd answer choice in it. Don't make it difficult. There is an odd answer choice. I want you to know that this steroid given to improve surfactant in preterm labor is what? Given as IM medication. That's all. So the steroid medication, betamethasone, is given as IM, not IV. That's what I'm testing. That's the concept you should take with you. And then it's assisting with the shoulder dystocia delivery. What is the concept? Shoulder dystocia. This is the way the NCLEX asks question. One line, straightforward. There's no ambiguity. This is what I hear from my students, and that's how I set my question. Straightforward, one line. Assisting with shoulder dystocia. No 4 lines, no 5 lines. This is it. Therefore, which action should the nurse take? You have to know what shoulder dystocia is. Basically, baby head come out, and then you go back. Total sign. It's because the shoulder is locked in place because the baby presentation is bad. If you present with the shoulder and there's a problem, we can deliver the baby now. What do you think? This is an emergency because remember, the head comes out and it goes in, and we have to do something quickly. The first thing you do is to time it. Like I said, these NCLEX practice questions are content review. I give you the content and you have to take notes so that you can use it in the form of giving you a long lecture. I give you everything you need to know. So the first thing is to know, you know the time. You call for help. Is to call for help. Note the time that it happened. Prevent the baby from retracting back by providing suprapubic pressure, not fundal pressure. Then perform Mac Robert, where the mommy knee is pushed to the abdomen, right? Or chest, right? You put it to the abdomen, and these allow you to be able to apply pressure simultaneously. And the doctor instruct the baby, the mommy, to do what they have to do to deliver the baby. We have shorter time. The longer it takes, we get into trouble. Therefore, what do we need to do? Suprapubic pressure and Mark-Robert maneuver will help dislodge the shoulder. Forceful pulling of the head is not indicated. The mommy has to still push, but not the vigorous one. The baby may need resuscitation because we have just 5 minutes to deliver the baby. Therefore, prepare for neonatal resuscitation, perform Mark-Robert, and apply suprapubic pressure. 3 and 4 are wrong answers. A postpartum client with the history of gestational diabetes. What is the buzzword? Gestational diabetes. I've given you a clue. Develop what? Excessive thirst. Buzzword, frequent urination. In a patient who have diabetes and have frequent urination and excessive thirst, bring your content. That is indicative of what? Excessive glucose, hyperglycemia. What do you want to do? Remember, hypoglycemic symptoms is like upper symptoms. You have tachycardia, diaphoresis, but these hyperglycemia symptoms, excessive taste and urination, will lead to dehydration. What do you want to do? Do you let them drink more water? Do you check your finger stick? Do you let the doctor know you are set for signs of postpartum infection? There's nothing in the question that tell you there's infection. I'm not giving any to you, tachycardia, or they complain about everything, anything associated with infection, or they complain about test and what? Urinary, frequent urination, consistent with hyperglycemia. Patient has gestational diabetes. You got to confirm it. There's no emergency. If there's emergency, you treat it. But since there's no emergency, you got to investigate more to confirm before you treat it. How do you treat it? You don't let them drink fluid. You check their glucose level and figure out what is wrong with this patient. That is the test-taking strategy you have to employ. Excessive testing, polyuria can indicate hyperglycemia. The next phase has to assess the blood glucose to confirm it before taking an action. A postpartum client, we are on number 7. Stop the video, count how many you got. You have 3 more. Redeem yourself if you're not doing well. But I know you watch Adapting Class, and I know you get 6 out of 6 already. I believe in you. Let's get to it. Number 7, a postpartum client is prescribed what? Methylergonovine for excessive urine what? Bleeding. Which assessment should the nurse perform before administering medication? Keyword, every time you see this medication, I know you know what to say. This causes vasoconstriction. Therefore, any condition that when you ensure vasoconstriction is going to worsen it, stroke, you should not take it. Heart problem, you should not take it. Hypertension, you should not take it. Therefore, what assessment would you do? Level of urinary tenderness is bleeding, but the question is not asking about bleeding. It's asking about what? Medication. This is how you can mix the point if you focus on wrong information in the question. The question says, prescribe what? Methylergonovine. And then the last portion said, assessment should be performed before giving what? Their medication. Their medication. Therefore, answer choice has to be related to the medication. Blood pressure measurement, assessment of Lochia color is talking about the bleeding. I don't care about the bleeding. The medication would do its job, but I need to make sure it is safe to give you the medication. Assessment maternal temperature. Once again, it has nothing to do with the medication. Therefore, what do? Check our blood pressure. If it's normal, we give you the medication, and the medication can do it. This is the key. BP must be assessed before each dose. A client of 24 weeks gestation report frequent headache and dizziness, 2nd trimester, and having headache and dizziness. That's a bad problem. You worry about complication during pregnancy. One of them is preeclampsia or gestational hypertension. What should the nurse do first? You check the patient blood pressure, let them rest, administer acetaminophen, and call the provider for referral. Figure out what is wrong. They were going to ask you, if you call the doctor and say, hey, what is the patient blood pressure? You give the acetaminophen. You think headache and associated dizziness. Headache should not, you use acetaminophen for headache that is isolated, just the headache. After you rule out bad stuff. Rest and hydration, you've done nothing. Therefore, let's check the patient blood pressure. Headache and dizziness can indicate preeclampsia. We should assess first to make sure there is no bad problem. A client, 18 weeks, right, beginning of his 2nd trimester, report pelvic pressure and occasional sharp pain on one side of the abdomen, not 2 sides, but 1 side. It's an occasional. Then you ask yourself, what kind of things will cause pain during 2nd trimester? If it's going to be ectopic pregnancy, I will tell you that. You'll see a clue. Now, what is the clue? Bleeding. There's no bleeding in the question. Don't bring anything. If it's a miscarriage, there will be some bleeding. You see, it's just straightforward. When you see your question, don't add anything. I said pelvic pain and sharp pain, pelvic pressure and sharp pain on one side. That tell you on one side of the abdomen, something is isolated to that side of the abdomen. This is normal, and due to ligament stretch, you should go to the hospital right now. Stop all activity until the pain resolves. This may be a sign of preterm labor. What do you know about preterm labor? Pain has to start from the back and go into the pelvis. I have to give you signs of consistent labor, regular contraction, some effacement, and there is nothing in the question telling you this is keep on going on. The word occasional defeats the purpose of preterm labor. Don't get trapped. And you know the answer. This is due to round ligament stretched. It's common during the second trimester. Therefore, teach them not to worry, but monitor it. If you continue associated with bleeding and cramping, yeah, you worry about the bad stuff, right? Preterm labor and other things. But this is common during the second trimester. And the last one, I know you get 10 out of 10. A client at 24 weeks gestation report vein on the leg becoming more prominent. You know your content. Pregnant lady, they're going to have engorged vein due to what? Maybe pushing on the IVC, inferior vena cava. What is the problem? This is the reason why you don't put the mommy on their back. You put them on their left side. Therefore, what advice would you give them? Avoid elevating your leg. Wear supporting stockings and avoid prolonged standing. Start vigorous exercise to improve circulation. This requires immediate surgery. What do you think? Think about it. Step back. I talk about vein. Bring your cardiology in. This is peripheral chronic venous disease. What kind of teaching do you provide to a patient with chronic venous disease? You know it. I know you know it. What do you think? The idea is to what? Prevent blood pooling into your leg. Therefore, number one is wrong. If you avoid elevating your leg, blood pool down, you have more engorgement. Stockings and avoid prolonged standing prevent blood pooling. Start vigorous exercise to improve circulation. It has nothing to do with that. It's due to blood pooling. Vigorous exercise is not going to affect the venous system, supposed to elevate it. This requires immediate surgery. It's expected finding, but we can do something about it. You don't need surgery. Therefore, varicose veins are common in pregnancy. Supporting stockings, leg elevations, avoiding prolonged standing help relieve symptoms. Therefore, number 2 is your right answer. What should the fundal height be palpated? A nurse is assessing a client at 19 weeks gestation. Where should you palpate when you're doing an assessment? At the symphysis of the pubic, midway between the symphysis pubic and what? The umbilicus. 1 centimeter below the level of the umbilicus, 2 finger breadth below the symphysis, what? 2 finger breadth below the xiphoid process. A lot of concepts. So I want you to write them down so that when you see your question, you remember that concept. The concept is when you're pregnant, the pubic symphysis is here. It's the 12-week mark. The umbilicus is the 20-week mark. And the xiphoid process is close to 36 weeks, right? So if I'm 19 weeks, I cannot be at the pubic symphysis. I should be close to the umbilicus. Therefore, I'm picking an answer choice close to the umbilicus. I cannot be above the umbilicus. Therefore, 2 finger breadth below the xiphoid process is gone. 1 centimeter below the level of the umbilicus. That is 19, close to that. Midway between the pubic symphysis and the umbilicus, that's here. It's less than 19. This is close to 16. Therefore, the right answer is what? 1 centimeter below the level of the umbilicus. This is the concept you have to master. And put it down, write it down, take it with you, and use it whenever you get a question. And that's the key. And therefore, at 19 weeks, the fundus is just below the umbilicus. And that is the content I want you to take with you. Number 3 is the right answer. Next question. A newborn at 1 minute has a heart rate of 120. good cry, some flexion, pink body with what? Blue extremities, and a weak grimace to stimulation. Somebody who took the test, it's a question on APGAR score. Why did they ask? Because it's very important. How do you calculate them? Straightforward. Stick around, take your pen, paper, and listen to what I'm going to see. There's a content associated with the APGAR. It tells us how the patient is doing. And the mnemonic is in the same name, APGAR. What does each letter signify? What does each letter mean? A is the appearance. How do you look? P is your pause. What is your pause? Grimace is your reflex. We don't use the R, but we call it reflex. Grimace. Activity is your tone. And the respiration is how fast is your respiratory rate. We want the kid's skin to look better. We want the pulse to be high, greater than 100. Your reflexes should be active, right? And then when you're active, your muscles should be working. Flexion, you get 1. Anything above flexion is good. If you're limping, you don't get anything. So when you're crying, you have good respiratory activity going on. And then the newborn heart rate is 120. That's good. He has a good cry. That's good for me. Flexion, that is your activity. You get a little bit less than the normal activity, so you get 1. Pink body, the body has to be pink, but the extremities is what? Blue. Therefore, appearance get 1. And he has weak grimace. That means with stimulation. You see grimace when they talk about stimulation reflexes, and therefore it's not going to get a full point. Based on that, this is what we're going to have. Heart rate is greater than 100, you get 2. You have a good cry, you get 2. Your tone, which is your flexion, right? You get 1. His reflexes, he has grimace, weak grimace, you get 1. In the process, what do we have? 2, 2, 1, 1, 1. Therefore, we have 7 as APGAR score. You got to master this. 10 is the best you can. If you get anything less than 6, we're going to repeat it again in 5 minutes until you keep on getting normal. That's the concept. And let's review a fetal monitor strip showing uniform deceleration, mirroring, contraction. This is all words. And NCLEX will use that to try to confuse you. If you don't understand the words, you feel like a hard question. Test-taking strategy, maternity, NCLEX practice question. I'm describing something on the fetal monitoring strip. What do I say? What did I say? Uniform deceleration, mirroring, contraction. How does the nurse interpret it? If this mommy contract, baby also have what? Deceleration, following exactly what the mommy is doing. If mommy contract, baby heart rate come down right away and go down. As soon as mommy contract, baby heart rate is going to go down. That's why I call uniform deceleration, mirroring, contraction. This is what we call early deceleration. And therefore, what will you do? You got to write your VCHOP mind, right? Early deceleration is due to head compression. And therefore, interpretation is a head compression. This is how you answer this question. And therefore, early deceleration are benign and it caused by what? Fetal head compression. Continue to monitor labor. Number 4, which condition most commonly causes what? Recurrent variable deceleration during labor. We've seen it, VCHOP mind, based on VCHOP mind. What do you think? A variable deceleration is equivalent to what? Cord compression. So therefore, most common is cord compression. This is a bonus, but you have to know it. I expect you to know it. I know you get 4 out of 4. Number 5, like I said, this maternity series, short, straightforward concept, no beating around the bush. And I tell you, if you know them, all these little things I'm saying, if you know them, when you see a question, you laugh in your head. You said, I got this. And then pop it, the funders, 72 hours after delivery. This is an NCLEX concept, Nancy school concept. You have to know. that when a mommy delivers, the baby fundus is supposed to descend. How? 1 centimeter each day, right? Where should it be palpated? At the umbilicus, 1 centimeter above the umbilicus, 2 centimeters below the umbilicus, not palpable below the pubic symphysis. The key and the concept after delivery, the fundus is supposed to descend what? 1 centimeter each day. And therefore, if this is the umbilicus, which is at what? 20, if this is the umbilicus, which is at what? 20 centimeters, and the pubic symphysis at 12, every day is supposed to come out 1 centimeter each day. 1 centimeter. And you can see that it can take between 7 to 8 days for it to descend completely, right? And therefore, at 72, you're going to have 1, 2, 3 centimeters below the umbilicus. That's your whole. That is your right answer. And therefore, fundus descend 1 centimeter per day postpartum. At 72, we should be 3 centimeters below the umbilicus. Is this question difficult? No. What it require? Concept. And what kind of concept? This is what you need. Write them down. Take a note. And when you see a question, trust me, you're going to ace it. Next question, number 6. A client with placenta abruption. This is ethical, fundamental on maternity of nursing. There's a bunch of ethics in this area of medicine. And this is what this question is demonstrating. A client with what? Placenta abruption require emergency C-section. The client just received opiate and is not fully alert. What action should the nurse take? You know it. You know this thing. Ethical. Watch my ethics videos on fundamentals of nursing. Obtain informed consent from the client. That's what you're going to do. Ask the client's spouse to sign the consent. The husband will sign the consent. Proceed with surgery under implied consent. Delay the surgery until the client is alert enough to consent. Look, in ethics, you got to follow fundamentals 101. She's impaired. She received opiate. She cannot do anything. Therefore, what do? Usually, it's okay to call family member. It's okay for the husband to consent. But this is the problem. This is the test-taking strategy right there. What do you think in the question that would defeat the purpose of asking the spouse? Need emergency C-section, and we have placenta abruption. We have no time. It's an emergency situation. If you don't do anything, baby dies, mommy dies. In order to save both of them, we need to go now. We don't have time for the husband to sign it. We cannot obtain consent from the mother because the client is impaired, right? We cannot obtain consent from the client because the client is impaired. We should proceed under implied consent, which is consistent with an emergency C-section. Delaying, patient dies. Concept, ethical, fundamentals of nursing under what? Maternity nursing. I will do some videos on ethical issues related to fundamentals of nursing. Life-threatening emergencies, treatment should not be delayed to obtain consent. Therefore, our right answer is, we all know, proceed with surgery under implied consent. Number 7, this is the same thing, ethics. A newborn parent refuses the administration of prophylactic erythromycin high ointment after delivery, stating, we don't want any unnecessary medication for our baby. What is the next best response? Be therapeutic. But when you be therapeutic, answer the question. If you don't know, ask for more. That is the easy way to be therapeutic. This medication prevents serious infection that could cause blindness in your baby. You speaking. I will have to give the medication because it's required by law. Mommy said, no, that is fine. I will just document your refusal in the chat. She's not being informed properly because of what she said. We don't want any unnecessary medication. What she's saying, something is wrong. She's misinformed. You should not take misinformation of the patient as a fact. Let me check with your provider to see if we can skip this medication. You are not happy. You want to save the parent. You want to save the kid. The mother is saying something that is not factual. Because of that, you got to make sure what they're saying is factual. It's like trying to get them whether they're competent about what they're saying. We don't want any unnecessary medication for our baby. This is not unnecessary. Educate them about the purpose of prophylactic, what is that? Erythromycin high ointment. These medications prevent serious infection that could cause blindness in your baby. When you tell the mommy like that, oh, I thought it was unnecessary, but now I know this is going to save my baby life. The priority is client education. Parent often refuses due to misunderstanding. They try to fill the gap in this situation, and you are the best person, the nurse. I know you got this. I know you get 7 out of 7. Put down on your comments what you get for this question. Number 8. A client in the second stage of labor is exhausted and having difficulty pushing effectively. What is the next best action? Encourage open glottis pushing with rest between contraction. Increase Pitocin infusion. Apply fundal pressure. Prepare for forceps delivery. This question is straightforward, but I want to show you something. You see a question like that, and then your mind is wide open instead of focusing on the keywords, buzzword. The question said, client is in second stage of labor. That means the baby is about to come, and then we are having what? Difficulty pushing. It's not saying that the cervix is not dilated or effaced. Therefore, what is Pitocin going to help you do? The question says pushing. Therefore, pick an answer choice that contains pushing, right? Number 2 is a trap. We are not saying the cervix is not dilated or effaced. I never said anything. So why would you pick Pitocin? These are little things that we pick, we get distracted. I said pushing. Fundal pressure does not help with pushing. Now you're left with 1 and 2. Do you want to help the mother, or you want to use forceps delivery? There is no evidence that the baby is in trouble. Therefore, maybe the mommy is not doing effectively, right? So help them. Encourage open glottis pushing with rest between contraction. And this is the way you push. Supportive care include coaching appropriately, breathing technique, rest, and non-invasive intervention before you use forceps. You see how you can answer this question. You don't know everything, but you have to use the taking strategy. You can master it. Number 1, right answer. During a prenatal ultrasound, same thing, ethics. The mother reports that the baby's sex not be disclosed. He said, don't tell anybody whether the baby is a male or female. Later, the father asked the nurse for the baby's sex. You want to give it to the father? What should the nurse do? The father is the father. They both are involved. Tell the father the baby's sex. It's a male, by the way. Refuse and document the request. Ask the mother for permission. Tell the father to ask the provider. Look, I told you, ethics 101 is all, everywhere, whether you're talking about OB, talking about any place in the hospital. Mother said, don't disclose anything. If you disclose, you violated HIPAA violation, you are in trouble. Therefore, obey the law. Confidentiality applies what? Even to the family. Nurse respects mother's wishes. You need to respect the wishes. Therefore, don't tell. A nurse review a newborn lab values and it shows elevated maternal serum alpha fetoprotein. What should the nurse suspect? Select and apply. Is it Dunstridge syndrome? Is it spinal bifida? Is it gastroschisis? Is it trisomy 18? Is it trisomy 21? The concept is neurotube defect, abdominal wall defect. What you're going to see is elevated alpha-fetoprotein. Any chromosomal abnormality will see alpha-fetoprotein go down. Therefore, what does that mean? If you have chromosomal abnormality, Down syndrome is trisomy 21, which is the same as this one. It's a chromosomal problem. Trisomy 21 is too high, and therefore you have this problem, Down syndrome. You can have trisomy 18. You can have trisomy 21. These will lead to low alpha-fetoprotein. Spinal bifida is a neurotube defect. Gastroschisis is the abdominal wall defect. This will elevate your alpha-fetoprotein. Know this concept. Whenever you see them somewhere, that is the concept you're going to talk about. Elevated alpha-fetoprotein will cause by what? Neurotube defect, abdominal wall defect. A low value is chromosomal abnormality. Therefore, by spinal bifida and gastroschisis are your right answer. What am I trying to teach you? Which teaching is most important for the nurse to provide? A client at 14 weeks gestation as a cervical cerclage placed. The concept is what? Cerclage. Every question, try to underline one key fact. But what is that? Cerclage place. Which teaching is most important for the nurse to provide? Report pelvic pressure or contraction immediately. Resume normal activities after discharge. Expect heavy vaginal bleeding for 1 week. Sexual intercourse is encouraged daily. What do you think? Cerclage. The content is cerclage. Go back to the content. What is cerclage? Cerclage is needed when the individual has incompetent cervix. Therefore, the cervix usually is supposed to hold the baby until it's ready to dilate and effaced, and the baby come out. Some women, the cervix are usually incompetent. So during the first trimester, before they get to the second trimester, early trimester, second trimester, the cervix dilate, they go into preterm labor, and the baby come out. Spontaneous abortion. Therefore, we place a suture there to prevent the cervix from opening. We call it cerclage. What do you think? Based on the content, what do you think you should provide the mother? Do you want them to have intercourse? Do you teach them that there's going to be a vaginal bleeding for almost a week? Resume their normal activity, or when they see pressure or they feel pressure, contraction, immediately they should report it to you. If they go in labor, they should let you know. Which answer choice tells you that the patient is in labor? These are concepts you got to write down and then master them. Sexual intercourse is going to cause problem. If you're bleeding for a week, you may be having complication. You should slow down. And therefore, your best answer is to call me when there is signs of labor. Pelvic pressure and contraction is not good. And that is the concept you should pay attention to. That's the concept you should pay attention to. So when you see a question, think about having labor as one of the things they should let you know. Therefore, we tell them to come in early before they go into labor. Signs of preterm labor or rupture must be reported as soon as possible. First question. A client who was at what? Pre-pregnancy BMI of 25. This, most people may not know how to calculate. This is a hard question, but it's not hard. I'll give you a concept, write it down. When you see a question somewhere, and Dr. NCLEX got you. She said BMI 25. Now, 20 weeks, right? Pregnant, and has what? Gained what? 9 pounds. What does that mean? Pre-pregnancy BMI was 25, and she's now 20 weeks and has gained what? And has gained 9 pounds. Which interpretation is most appropriate? The weight gain is excessive for 20 weeks old. This weight gain is appropriate for gestation age. This weight gain indicates a risk for what? Intrauterine growth retardation. That means the baby is not growing. This weight gain shows a need for bed rest and fluid restriction. What is the concept I want you to take with this question? If you don't know, remember it and write it down. Whenever you're at first trimester, everybody, no matter your BMI, you're going to gain 1.1 to 4.4 pounds. Everybody is going to gain this, whether you are overweight, underweight, obese. At 25, she's overweight, slightly overweight. 24.9 is normal BMI. So it does not matter. After the end of the first trimester, she can gain a maximum of 4.4. So we will assume when you're doing calculation, assume she gained the maximum 4.4. Then 20 weeks, 8 weeks is left. That means 12 weeks is the first trimester. We're taking 12 weeks as the first end of first trimester. And therefore, 8 weeks, she has 8 weeks left. Because she's overweight, she's going to gain 0.6 pounds every week. So for 8 weeks, she's going to gain this. This will be close to 4.8 pounds, right? So this is what she will gain, 4.8 pounds, because 0.6 is times 8 is 4.8. And therefore, what do you think? 4.8 time plus 4.4, this is 9.2. So a total of 9.2 pounds she's supposed to gain in addition to a original weight. What did the question say? She gained 9 pounds. Therefore, the weight gain is not excessive. The weight gain is appropriate. The weight gain does not indicate intrauterine growth retardation. The weight gain shows a need for bed rest. It does not. So this is the concept I want you to take with you. That weight is based on what your BMI is before. At 25 weight, gain 4.4 pounds first trimester. And then at the end, she's going to gain 0.6 pounds every week until the end of her pregnancy. And so this is key that you're supposed to know, and that is appropriate weight gain. Which vaccine is safe for a client at 26 weeks gestation? Write it down. I need to know vaccination for pregnant patient. It's a key concept. Every question, that's the buzzword, that's the trap, that's the NCLEX content you have to take with this video. Therefore, ask yourself which one is live and which one is non-live, because the pregnant lady should not take live vaccine. MMR, varicella, Tdap, and a nasal flu. Know this, write them down. These are your live vaccine, right? These are your live vaccine. Varicella is a live vaccine. Nasal flu is a live vaccine, but IM form is not, right? MMR is also live vaccine. They are not safe in pregnancy. Tdap is good. If you give the lady inactivated flu, which is the IM, it should be fine. Therefore, the right answer is a Tdap. She's going to get a Tdap, and she's not going to get MMR, varicella, and nasal flu. I know you're getting the concept. You see what I'm trying to do. I'm not going to give you really complicated lecture, but I'm using this to show you the concept you're supposed to memorize. And I know, and I want you to write them. I need to know vaccines and how they give it to a pregnant patient. I need to know live versus on-live. That's all. That's the concept number 3. The next question, this is the hardest of all, but don't worry. If you are in a nursing school watching this, I want you to take a note. If you're preparing for the NCLEX, also take a note. Those calculations are strategy. There's a strategy to tackle it. How many ml per hour should the pump be programmed to deliver? The provider prescribed Pitocin 20 units in 1,000 ml per liter to be infused at what? 12 milliunits per minute. The nurse will use the pump at which rate? Don't worry, I got you. Every time you see a dose calculation, go to the answer choice. What is that? ml per hour. Write it down. I need to do ml per hour. And that's all. As soon as you do that, all you need to do is whatever they've given you
flip them back and forth to get into this shape. I see ml here, and I see 20 units. Therefore, 1,000 ml need to go up. 1,000 ml over 20 units. That's the first thing. And since this is a milliunit, I need to convert the unit into milliunit. Therefore, I have 1 unit over what? 1,000 milliunit. Now, I bring my milliunit 12 milliunit over minute. I need to have hours. So I convert the minute into what? 60 minutes into 1 hour. You done. Cancel everything. Unit cancel unit. Milliunit cancel milliunit. Minute cancel minute. And you have hour down. You have ml. And the 1,000 cancel 1,000. What is this? 60 and 20? This would be 3. Therefore, you have what? 36 ml per hour. Number 1 is our right answer. This is the key in answering those calculations. But this is another way to do that. Always convert the units so that they are the same into milliunits. Then because most of the infusion will be in the milliunit. Then convert the milliunit into hour. So that's what we do. We convert the unit into milliunit and then milliunit into hour by bringing our time. This is those calculation with Pitocin. And this is a nursing school NCLEX question you may see. This is the next question. An 18-year-old client with the history of Marfan syndrome is pregnant. What is the nurse priority teaching? You are at risk for aortic rupture during pregnancy and delivery. You will need additional screening for gestational diabetes. Your baby will likely be large for gestational age. Oral contraceptives are recommended postpartum. Why do I give you this question? Because I want you to know this concept about Marfan syndrome and pregnancy and why at this age they have connective tissue disease. So their aorta is not that strong. The connective tissue, there's a problem with collagen issue, and therefore they have dissection of the aorta. They will get dissection of the aorta, and because of that, we teach them that you should not get pregnant, but if you want to get pregnant, you should do that at early age when you're stronger. That's why 18-year-old is pregnant. But what is the priority action? Of course, we're going to prevent you from getting pregnant, giving you oral contraception. It has nothing to do with gestational diabetes, right? Your baby is not going to get bigger. We don't need to screen you for diabetes either. But the biggest problem of these patients is aortic rupture during pregnancy and delivery. And therefore, that should be what the nurse should prioritize so that when they're ready to deliver, they have everybody available to help it. Therefore, number 1 is the right answer. Aortic rupture and dissection risk is the major concern in pregnancy with Marfan syndrome. This is the key that you have to pay attention to for that question. Number 6, what is the key here? A client 1 week postpartum, 1 week exhibit what? Hallucination and disorganized behavior. What do you think? Stop the video. Answer the question. Let me know what you think. What is the priority intervention? Refer to a support group, schedule outpatient counseling, initiate antipsychotic therapy and hospitalization, provide reassurance that symptoms will resolve. What do you think? This patient, is it postpartum blue? That was the purpose of the question. It is postpartum depression? That was the purpose of this question. Is this postpartum psychosis? That is the purpose of the question. The presence of hallucination and disorganized thought means what? Means what? You know it. You know your mental health. Bring it together. Hallucination, disorganized thought process. This is consistent with psychosis. When you have postpartum psychosis, the management is what? Inpatient rehabilitation and antipsychotic. Refer to support group is designed for probably blue. Schedule outpatient counseling, also blue, and depression. initiate antipsychotic therapy and hospitalization consistent with psychosis. Provide reassurance that the symptoms resolve. They are not going to resolve. They need rehabilitation, inpatient, and psychosis. Therefore, what is your right answer? As we said, underline it and you pay attention to it. Hospitalization, antipsychotic. Number 3 is the right answer. Number 7, and this is the key. Postpartum psychosis is a medical emergency. Hospitalization and antipsychotic are your key. A client with gestational hypertension, she has hypertension, not preeclampsia. Pay attention to it. Which prescription should the nurse anticipate? Right? Select or apply. Levodopa, magnesium, daily blood pressure monitoring, fluid restriction, immediate oxytocin induction. Stop the video, put down your answer. Let me know what you think. Let me know which one is affecting you. Think about it. I hope you're writing the concept down. There's a concept question here that you have to know. Maternity NCLEX practice question and NCLEX answers, questions and answers. Maternity nursing concept for the NCLEX and nursing school. That's what we're talking about in a mini series of practice tests. The key is what? Gestational hypertension. You have to know the difference, right? If you have hypertension before 20 weeks and you're pregnant, right? That is what? Chronic hypertension. If you have hypertension after 20 weeks, you have what? What we call gestational hypertension. If you have associated neurological symptoms, you have something we call pre-eclampsia. And you have seizures, you have eclampsia. In this situation, she has gestational hypertension. We want to prevent it from going pre-eclampsia. So definitely, we're going to give a blood pressure medication, Levodopa. Definitely, we may have to give a seizure prophylaxis. That is what magnesium is going to do, right? Definitely, we're going to monitor her blood pressure daily to prevent her from getting into trouble. We're not going to fluid restrict her, and we're not going to provide Pitocin. There's no indication for the baby to come out. So this and that are some expectation the nurse should expect from the doctor will be ordered. So antihypertensive is number 1. Seizure prophylaxis, right? And then monitor your blood pressure so that it doesn't develop. What is the nurse priority action? A client receiving Pitocin for labor induction develop what? Recurrent late deceleration on the fetal monitor. Pitocin stopped. We already stopped it. What is the nurse priority action? Do you call the doctor? Do you start IV? You apply oxygen or place the client on the side? This is a concept you have to know in case you take the NCLEX and you see that we have what? Recurrent late decel. If you write VCHOP mine, you will figure out that, that this is the problem, right? If you write it and then you remember we have recurrent late deceleration, which is consistent with placenta insufficiency. That means something is wrong. There's no blood flow from the placenta. And therefore, what we do is lie on after we stop the poison. We have stopped the poison. The first thing you do is your lion. That's what the question is saying. I need to stop the poison. I stop the poison. Next thing, do you call the doctor? IV fluid, oxygen, or place the client on the lateral position? You can see based on the lion, lateral position is the right answer. So number 4 is the right answer. And that is the purpose of this question, to let you pay attention to the order of treatment. It's very important. So late decel is placenta insufficiency. First action, stop Pitocin. But then after that, focus on what? The lion, which is what? Lateral position in this patient. What is the next priority action? A client memory rupture spontaneously during active labor. What should you worry about? When your memory rupture, do you document the time it happened? The word said priority. When your memory rupture, do you assess the fetal heart rate? The word said priority. When your memory rupture, do you note the color and the order of the fluid? The word said priority. Monitor the client contraction. The word said priority. What do you think? When your memory rupture, all the fluid comes out and the placenta comes with it. You can have what? Cord prolapse. And therefore, how would you know the baby will have deceleration? So you check the monitor, but you want to make sure there is no cord prolapse. How do you assess it? You do vaginal exams and see if there's cord prolapse, or you look for the fetal heart rate on the monitor. What do you think is your right answer? Documenting the time is okay. Checking the color and the order is okay. Monitor the contraction is okay. But the word priority, I got to look at the baby. Is the baby decelerating? Then I need to do something. Number 2 is the right answer. Therefore, after a rupture of memory, priority is to assess fetal heart and look for cord prolapse. Last question. I know you got it. Put it down. Let me know. The client at 28 weeks has a 1 hour 50-gram oral glucose tolerance test of 142. What do you want to do? Document this as normal. Schedule the patient for 3-hour test. Notify the provider for hypoglycemia. Repeat the test immediately. Random 1 hour 50 oral glucose test is a screening test. When you screen it, it tells you whether the patient needs additional tests or they don't need any additional tests. 140 is your magic. If you're less than 140, you're good. But if you're greater than 140, we have a problem. 142, we have a problem. Therefore, what do you want to do? We got to do more tests. What kind of tests we have to do? Mommy has to fast. So we got to do 3-hour fasting tests. And that is the right answer. Documenting this as normal is wrong answer. Notify the provider of hypoglycemia. No, we got to look and make sure we test again. Repeat the test immediately. No, because we got to fast. Therefore, number 2 is your right answer.
What do you think? Test taking strategy. I'm going to give you keywords. What you need to focus on. Which intervention is the nurse priority? That means she has to do something as a priority. She has 4 options. 1 second. Go for the buzzword. What is the buzzword in this question? A client at 32 weeks presents with what? Contraction and back pain. And then I'm asking you to find the nurse priority action. What do you think the nurse should do? Start IV Oxytocin or administer prescribed tocolytic or prepare for what? C-section, encourage frequent ambulation. To answer the question, go back to the buzzword. What is the buzzword? We have the 32 weeks old. What is she doing? Contraction and back pain. Something should be ringing in your ear right now. If you don't connect the dot, you're going to get it wrong. This patient is having contraction and the back pain. She's 32 weeks. Classify them. Put her in the situation. What is the problem? Test taking strategy. I'm trying to get you thinking critically to answer this question. She's at 32 weeks and contraction and back pain. This is what we call preterm labor. She has preterm labor. These contraction and back pain are back problem. Therefore, what do you want to do? Look at the answers. There's 2 answers that are contradicting each other. Number 1, say give the lady Pitocin, causes contraction and help augmenting the cervix and effacement. But then number 2 said administer tocolytic, slow the mommy down. 3 and 4 does not answer the question. Preparing for C-section does not answer the question because we don't need to. She's not in trouble. There's nothing we can see that she's deceleration or anything or recurring deceleration, right? Encourage frequent ambulation. You don't do anything. Therefore, do you want to slow this lady down or you want her to continue to contract? That's the key concept. to answer the question. And as you can see, we have a lady who is in preterm labor. We need to give the lady Cerclage, either terbutaline or nifedipine, be able to identify in the question and then be able to answer it. The reason why maternity shows up because of these concepts that you have to take the concept and apply it. Therefore, this patient, we need to give a Cerclage, and therefore number 2 is the right answer. All the questions are going to be like that. And I want you to be able to stop the video, pause it, answer it, and then see the way I'm going to answer the question. Number 2, which interpretation is correct? A nurse is assessing a client in active labor, okay? The fetal station is documented as -2. Which interpretation is correct? This requires a little bit of content, but like I said, it's a basic. If you don't know anything about maternity for the NCLEX, these are little things you have to know so that when they throw the hard ones to you, you'll be able to at least make your way through, be able to answer it. Therefore, you have to know what is a station. And this station is respect to the axial spine, which is 0. If you're negative, it's above it. If it's positive, you're below it. The more positive you are, the more you're about to come out. That's all. That's the concept. Therefore, I've given you the concept. Manius, you are above the axial spine. Therefore, which one is your right answer? You see, it's popping out like a candy based on the concept. I went for the buzzword. I said what? Interpretation. And I said what? Fetal station. I understand what fetal station means. And fetal station in this situation is respect to what? The axial spine. If you are negative, you are above the axial spine. If you're positive, you are below. Therefore, she's negative. What do you think? Answer choice, like I say, is popping. Engaging is the beginning. 2 centimeters above the axial spine. Look like I'm doing something good. 2 centimeters below the axial spine. I'm all the way down. Crowning all the way down. Therefore, 2 is your right answer. But you can see how we just take the concept and use the concept to use it. Answer the question. A negative station is above the axial spine. Engagement occurs at the 0 station. Same thing, be able, in case they give you images or they describe it, able to know physiological changes in pregnancy. This is something you have to know. It's not esoteric. A pregnant client report new skin changes. New skin changes, which finding is most concerning. What do you think this is? What do you think this is? What do you think this one is? What do you think this one is? As you can see, common sense should tell you, look, there's one that look ugly and there's one that look like normal skin changes, right? You can't tell me you're going to pick number 1 because you've seen it multiple times. You cannot tell me you're going to pick something this in your face and leave this alone. You can't tell me you're seeing these lines in somebody's abdomen and pick that one and then leave this alone. This is ugly. This looks like a mole, and he has jaggy edges. The skin changes are different. There's variation in the skin. This is a bad mole. I'm going to pick this one. And like I said, concept, there's taking strategy, and this practice question, maternity, telling you things that you need to know for your health promotion to answer this question. Linear Niagara is that one. Colosma, right? Is in your face. And the abdominal striae is that one. This is bad. Number 5, a client with severe pre-eclampsia is receiving continuous infusion for magnesium sulfate. Why? Because we want to prevent you from having eclampsia, having seizures. But then what is the problem? Which finding require immediate intervention. Stop the video, answer it on your own, and see the way I'm approaching it. You see, I'm going for the concept and ask yourself, magnesium, what is its function? It slows things down. Therefore, everything is going to go down. I see reflex is going down. I see respiratory rate going down. I see urine output is not going down. 550 ml every hour. That's a lot of urine. Blood pressure, 150 over 90. It's not that bad. It's normal. Therefore, somebody who's going down is 1 and 2. Your reflexes or your respiratory, which one is a priority? The question says immediate intervention. I'm going for your respiratory rate. That's more serious than your reflexes going down. Number 2 is your right answer. Which finding require immediate follow-up? And it's review the results of a client contraction test. Thus, you have to know contraction stress test and a non-contraction stress test. These shows up every time. Nursing school or NCLEX. It's confusing, but it's not. You have to understand. Contraction test, you want to know if the baby can tolerate labor. And when mommy contract, would the baby heart rate decelerate? That's all. Therefore, we're looking for immediate intervention. If the baby heart rate decelerates during contraction, after we stimulate the mother, that's contraction, that's a bad problem. A negative test means no contraction. A negative test means baby is not decelerating. A positive test means we get a positive sign. Baby decelerate during contraction of the mother. Suspicious results is whatever it is. There's nothing about the results that is suspicious. It's either positive or negative, or reactive or non-reactive, right? Unsatisfactory is what? Results is what? It's nothing. It's not telling you anything. The right answer, we have a positive results. A positive results means mommy decelerates. A positive results mean baby heart rate decelerate during contraction of the mother. That's a bad thing. So that's the answer choice here. So a positive contraction test is what? Late deceleration with contraction. Number 7, a client undergo non-stress test. Now, non-stress test. There's no stimulation of the mommy. We're just seeing how the baby is doing, the well-being of the baby, and therefore, which results require further evaluation. If we're looking for deceleration for contraction stress test, the opposite is what? Non-stress test means what? There is no deceleration. If you're not going down, you should be going up. I'm using analogy so that you can figure out if it confuses you. Now, I want to go up. That means acceleration. How far do you go? How many times do you should go up? Is the key for non-stress test. At least supposed to go up twice, acceleration. It should last for at least 15 seconds. And within 20 minutes, you should have 2 acceleration. And how high should it go up? At least 15. This is the concept. Play that portion again, write it down so that when you see a non-stress test, you know what to do. You're looking for at least 2 acceleration within 20 minutes. It should be 15 seconds duration. And then the heart rate should go up minimum 15. Therefore, what do you think? 1 acceleration in 40 minutes, 2 acceleration in 20 minutes, baseline 140 with the moderate variability. Moderate variability means you're going up to like 25, so it's good. Acceleration lasting 15 seconds and 15 beats per minute above baseline. You can tell based on the criteria I've given you, you need to select this. This is concept. Write it down. Go and learn them and master them and come back, watch this video, and you see you answer all of them right. Which are considered probable sign. It means what? Probable sign. That means something that we can examine you and we can figure it out, right? A probable sign. A positive sign, we're doing a test using something to look inside the uterus to be able to see if there's a baby there, like getting ultrasound, right? If can see the baby there, it's a positive. If the doctor can do a test and can say, hey, there may be something there, yeah, that's probable. If mommy is complaining about it, that is what? Presumptive. You see fetal movement felt by the client right away. Mommy is talking. Therefore, that is what? Presumptive. A positive test. We did the test. That proving probably something is there. It's a probable. Balancement, right, baby? Up and down, but during examination, right? Chadwick's and Eger sign. These are examination in the vagina that the doctor can determine. You know it. I know you know it. These are little things. If you don't know, this video is designed to give you the basic, but concept. NCLEX is not supposed to be that big. These little concepts, if you had it together, whenever they ask you a question, you'll be able to answer it. Key concept to be able to know what is the difference between positive, negative, and a presumptive test. Probable sign, objective. That means observed by the examiner. Fetal movement is felt by the mother. Therefore, you know which are the right answer. It's a select or apply. You don't have to pick everything. Da, and da, except number 4. Number 4 is not one of them. And let's explain what? Erythroblastosis fetalis to a client. This is a question you may see. Know it. Look for it. Go read about it. But this video gives you everything. Which maternal condition places the fetus at the greatest risk? Which maternal condition places the fetus what? At the greatest risk? And next, explain erythroblastosis to a client. Which maternal condition places the fetus at the greatest risk? What do you think? Is it ABO incompatibility, RH incompatibility, gestational diabetes, or preterm labor? The concept, you may see it in the NCLEX, and you will figure out that sometimes they will trap you on it. But it is what it is. Erythroblastosis fetalis. That means blood cells are breaking down and the baby is dying. How does that happen? Is it because of ABO problem, RH problem, gestational diabetes, and preterm labor? You know it, but I use different word. This is what the NCLEX will use to trap you. Erythroblastosis fetalis is RH incompatibility. Mother is RH negative, giving birth to RH positive, and this is what we're having. Baby is dying. Watch for that. Watch for this concept. Don't let them trap you. Adapt NCLEX, get your back, and this is your right answer. Number 2. Don't forget about it. Every time you see it, go back to RH negativity. And then should respond that quickening usually occur when? Watch for ages, time, mommy can feel. First trimester, second trimester, what they need to know, which situation, which time do you feel quickening? What do you think? How would the mommy know this? What time? They may say which of this you should intervene. Mommy says she's feeling the baby when the baby is 8 weeks. Do you think it's appropriate? 10, 12 to 14 weeks, 16 to 20 weeks, 28 to 30 weeks. Common sense to tell you, test taking strategy to tell you, 28 to 30 weeks, you should have fed the baby long time. 16 weeks is the minimum time you should feed the baby. Therefore, 16 to 20 weeks. These are little things I want you to get it before you go and take the NCLEX. Challenging, but not. Focus on the buzzword. And let's note fetal heart rate deceleration that mirror uterine contraction. That is the buzzword. Which action the nurse should take? What do you think? Which action the nurse should take? Before you answer the question, how do you answer questions? Step back. Don't pick an answer. Go for the buzzword so that you understand what the examiner is asking you. The question says the fetal heart rate. Why did I put mirror? Mirror uterine contraction. That means if this is uterine contraction, the fetal heart rate is going to do the same. It's going to mirror it. The fetal heart rate deceleration, right? Not acceleration. The fetal heart rate deceleration mirroring maternal contraction. That means if mommy contract, the baby heart rate go down. Mommy stop, the baby heart rate stop. This is what it means. Which action the nurse should take. Contraction, there is deceleration, but the deceleration is mirroring what the mommy is doing. What kind of deceleration is this? Before you answer the question, you have to define it. Is this early deceleration? Is this late deceleration? Is this variable deceleration? And after you define it, you can answer the question. If this is early deceleration, what do you expect? Assess for cord prolapse, place the client in the left side, continue to monitor labor progression, or suspect severe fetal hemolysis. If this late deceleration, what do you expect? If this variable deceleration, what do you expect? A deceleration that mirrors that of the uterine contraction is an early deceleration. Therefore, I'm not going to look for cord prolapse because if I write my veil chop, I know that cord prolapse, right? Usually, what would it present with? It presents with variable deceleration. Therefore, this is wrong. Place the client on the left side. Mostly, I'm talking about placenta insufficiency, and this is usually represented as what? Late deceleration. This is no problem. Continue to monitor labor progression. It has to be what? Early deceleration, which is what this is showing. Therefore, I'm going to monitor that. Suspect severe fetal hemolysis. This is sinusoidal problem. It does not indicate that. These are all concepts. Every question, there's going to be a concept. I want you to take a pen and paper and write it down. The concept here is what? You have to understand what? Deceleration mirroring that of uterine contraction is what? An early deceleration. So the right answer is number 3. And that is the key here. Early deceleration is a benign, it's due to head compression. And therefore, number 3 is our right answer. And then reviews the client fetal monitoring strips and note moderate variability. What do you know about moderate variability? That is the buzzword. Don't answer the question until you figure out what is moderate variability. Every question, trying to come out with your own answer. What action should the nurse take? What's the best action? You have to understand what is moderate variability. If you understand it, do you think we need to give the patient oxygen? Do you think we need to place the client on the left side? Do you think we need to monitor the client? Do you think we need to notify the healthcare provider? The word variability means go up and down. And moderate is within a certain range, at least 6 to like 25. That means the baby heart rate goes up and down by that time. A minimal variability is a bad thing. No variability is also a bad thing. A moderate one means good. A baby heart rate should go up and down at a certain range. And therefore, moderate variability is a good thing. Therefore, what do you think we should do? Just monitor the kid. That's all. That's the key. Like I said, every question, there's the concept. And I want you to write it so that you can master maternity in nursing school and the NCLEX. Moderate variability is reassuring. If it's reassuring, then I should continue to monitor. And as I says, a pregnant client in the second trimester. What do you expect in second trimester? Which findings should be reported? This is what we call physiological changes in the pregnant lady. This is video number 10. This is the series that will help you understand maternity. Linear Niagara on the abdomen, should that concern you? Supine hypotension when I lay flat. My blood pressure goes down when I lay flat. Is there a problem? Plus 2 PD edema in the ankles after what? Prolonged standing. And a diastolic murmur. What do you think? Second trimester lady has the following, second trimester lady with the following features. What will concern you? These are expected findings that you have to master them, but which one do you think is not an expected finding, or which one should concern you? Linear Niagara is normal in pregnancy. When you lay flat, when you're pregnant, your blood pressure goes down. That's why we want you to lay on your side. So it's an expected finding. Teach them not to lay on their back. Just because I say hypotension is when they lay flat, not normally. And then periedema. This is not preeclampsia because after prolonged standing, just by elimination, you know this is right. A systolic murmur in a pregnant lady is normal because of an increase in fluid volume or increase in blood volume. A diastolic murmur is unexpected. It's a bad problem, indicate cardiac problem. And I want you to write it down. Every time they give you a question on a pregnant lady and you hear a diastolic murmur, know that this is a problem. That is your right answer. Concept-based maternity nursing NCLEX review to help you master this in nursing school and NCLEX. Diastolic murmur is a pathological problem, and therefore number 4 is your right answer. This is talking about movement of the baby, and it's teaching a client at 28 weeks gestation about fetal movement. Which statement indicate correct understanding? What do you know about fetal movement? Concept you have to know. I should feel at least 10 movements in 12 hours. I will call my provider if I don't feel 10 movements within 2 hours. If I feel the baby move less than 3 times per day, I should lay down and wait. Kick count should only be done after 36 weeks. It's normal if the baby doesn't move for an entire day. Ladies and gentlemen, nurses, what do you think we should do? Which of this is correct? Correct understanding. 10 movement in 12 hours. I don't feel the baby in 10 movement within 2 hours. And then less than 3 times per day. All of this, what do you think? Put down your answer, stop the video, answer it on your own, and then see the way I'm going to answer it. And then you can take the concept from there. I can tell you for the NCLEX, at least 10 movements in 2 hours is the best. Anything else is not good. 10 movement in 2 hours. Once again, 10 movement in 2 hours. Therefore, I should feel at least 10 movement in 12 hours. No, the idea is 10 movement in 2 hours. I will call my provider if I don't feel 10 movement within 2 hours. That is good. If I feel the baby move less than 3 times per day, I should lay down. You should call because look at number 2. Number 2 said 10 movement within 2 hours. If I don't get them, I'm calling the provider. But you said 3 times, you're going to lay down and let things take its course. No. Kick count should only be done after 36 weeks. Does not make sense. You should continue counting every day. It's normal if the baby doesn't move for an entire day. That's wrong. Therefore, there's only one answer. It's a select or apply. If you know only one, pick it. If you pick more than one, you get it right. Therefore, only one answer is the right answer. A client at 28 weeks asks about vaccines. Which should the nurse recommend? This is vaccine. This is some of the things you have to teach the patient. This is what the NCLEX like. They love this. A pregnant client at 28 weeks asks about vaccines. Which should the nurse recommend? Select or apply. The NCLEX love these anticipatory guidelines, things you teach them, because it shows that you know the content. Tdap, MMR, varicella, influenza, and HPV. What do you think? Pregnant lady is immunocompromised. You should not give them live vaccine. Which of this is a live vaccine? That is the concept. What is your answer? Put it down. Number 5. 5 questions. I know you get 5 out of 5. Put down your answer. Let me see what you got. But the concept is MMR and varicella are contraindicated. HPV is also contraindicated. Influenza inactivated one is the IM, is good. The flu nasal one is not good. Therefore, Tdap and influenza is the best answer. MMR, varicella, and HPV are active. This is concept question, and it's good to know it because you have to teach the parent. A client with the history of thrombophlebitis asks about contraception. Which method is safest? Think about it. Thrombophlebitis, that means you develop clot in the past. Clot in the past with inflammation. It does not matter. So far as it's in the vein, you develop some clot. What contraception should you recommend for the patient? The key is estrogen. It's a bad one. It causes DVT. Therefore, anything that has estrogen in it, you should avoid it. If you have a history of DVT, that is the concept. That is what you should focus on. Based on that, what do you think is your right answer? Combined oral contraception, yes, estrogen. Progesterone only, no estrogen. Estrogen patch, yes, estrogen in it. Vaginal estrogen ring, yes, estrogen. Concept. And you know, number 2 is the right answer. That's all we're doing. This question is about knowing the concept. You can use it to answer any question. I want you to write it down as a note and keep on going back to them and reading them. You see that maternity will be like a cake. And next is teaching about cervical cancer screening. What is the concept? Cervical cancer screening. What do you know about it? Take that, what you know, and look at the answer choice. If they say something wrong, ignore it. With statement by the client, indicate correct understanding. I will begin pap smear at the age of 21, regardless whether I'm sexually active or not. Pap smear are done yearly after the age 30. If I'm not sexually active, I will not need a pap smear. What do you think? This you know. I know you know. It's in the question form. Figure it out, right? Cervical cancer screening, you do it 21 years. That's when you begin. And you do it every 3 years if it's normal. The key concept here is cervical cancer screening is done at 21 years, no matter your sexual activity or not. The other one are traps. If you're sexually active at early age, your risk of cervical cancer increase. If you smoke, your risk of cervical cancer increase. HPV vaccine does not prevent you from having cervical cancer. You still need screening. A vaccination is a preventive. Pap smear are not done yearly after 30 years, 3 years. Therefore, the right answer is number 1. And this is very, very important how you know about it. A client in the 3rd trimester, report of shortness of breath when laying flat. Which instruction is best? This is unexpected in pregnancy. Use extra pillow when resting. You may be developing preeclampsia. This indicates preterm labor. You should restrict fluid at bedtime. What do you think in this situation? The 3rd trimester with the gravid uterus, they lay flat, they have shortness of breath, and they call you. What do you tell them? Is clinical common sense question that you have to make it easy for yourself. What you have a gravid uterus. If you lay flat, you become hypotensive, shortness of breath. What do you tell them? Unexpected finding. There's no indication you have to pick preeclampsia because it's a bad problem where it does not answer the question. There's no indication that she's having contraction. It can be preterm labor. Fluid restriction is not good. Therefore, 1 is the right answer. A client at 9 weeks report morning nausea. This is the same thing. These questions are made straightforward so that we can use some common sense to answer them and say, look, this is it. I've not making it harder or not. Morning nausea. Well, help with the nausea. It happens in the morning. Which recommendation is appropriate? 1st trimester. Nausea, well, eat 3 large meals. Well, it's like a reflux. Reflux patients should not be eating 3 large meals. Drink fluid with the meal to promote digestion. You're going to have nausea more. Crackers, come on, man. Before getting out of bed, something to prevent you from having nausea. Avoid protein in the morning. Protein is the best one that is supposed to have. Therefore, crackers is the key. These are the things you have to teach the patient. And the last question. This is not difficult, but this is to trap you. And then she's teaching the client what? In 2nd trimester about expected cardiovascular changes. Think about it. If you think about this question, it will be easy. What statement indicate understanding? Well, when you're pregnant, you now have more volume. Your blood volume goes up. Your heart rate goes up. Your hematocrit may go down, right? Your blood pressure alternate, go back and forth, and later on stabilize. Therefore, my blood pressure will rise steadily throughout pregnancy. It's not going to remain the same. My heart rate may increase by 10 to 15 beats per minute. It may sound like, right? I should expect my blood volume to decrease. Well, you have another baby, more blood. My cardiac output remain the same as before pregnancy. You have more blood. It's not going to remain the same. The key is your blood pressure and your heart rate and your cardiac volume is going to change. And what kind of changes you should expect? Your heart rate is going to increase by 10 to 15. Your blood volume about 40 to 50%. That's a lot. And your cardiac output will increase. Therefore, number 2 is your right answer. Thank you very much. Postpartum client expresses what? Concern because a newborn's eye occasionally appear crossed. Which teaching should the nurse what? Provide. This is what the mother is saying. There's a clue here. There's taking strategy. You don't have to look for time, date, because I've given it to you. It's a postpartum. That means mommy just delivered. And the newborn, probably less than a day old. And then what did the mother see? It appeared that, oh, the eyes are crossing over sometimes. And this is what the mommy is seeing. One is getting closer to each other. What do you teach the mother? Is this a newborn normal finding? Would this baby need glasses? Do I begin to patch one of the eyes? Is this a serious neurological problem? What do you think? This is what we call strabismus. It's a common NCLEX question. If you've never seen it before, I want you to read about it because they can ask you. It will appear in the NCLEX or nursing school. You have to know how to teach the parent. That's why the mother is asking you. That's why I'm asking you to. What do you tell the mother? The content here is what I'm going to give it to you. I want you to take a pen and paper and write it down. Very, very important. What do you need to write? That time is very important. We have something we call intermittent strabismus. This is common in newborn because the muscles of the eye are immature and it can be present for up to 3 months. After 3 months, if the eyes are crossing over, then that's a problem. It's a pathological problem. After 3 months, getting to 4 to 6 months, you have a problem. That means we got to do something about it. But for now, nothing to do. So what should the next tell the mother? This is a normal finding. If it persists 4 to 6 months, you may need surgery. You may need to patch the eyes so that it can recover. But which eyes do you patch? The stronger one. That's the most important. And the kid may need corrective lenses and after surgery. So that's the content. After 3 months, it's okay. But after 3 months, 4 to 6 months, when it persists, we have a problem. Strabismus. Know this content. Which interdisciplinary consultation is most appropriate? A nurse is caring for a client admitted with what? Hyperemesis gravidarum. What is the concept? What is the keyword? Hyperemesis gravidarum. When you see that word, you know that this patient is either dehydrated and having problem with dehydration and nutritional problem. Who are you going to call? Occupational therapy, speech therapy, nutritionist, and physical therapy. You know the content. You know the patient can walk. They can do all the skills that they need. They don't need a physical therapy. They don't need occupational therapy. Now you're left with nutrition and speech. Speech, usually swallowing problem. This patient does not have swallowing. They need to eat certain food so that they don't have nausea and vomit on themselves. Therefore, dietitian are the best person to call. Severe vomiting leads to nutritional electrolyte imbalance. So dietitian help with what? Nutritional support and meal planning. They are the best people. Which question should the nurse ask? What do you think? If you are in that situation, a client report breast soreness, my breast hurt, urine frequency, I'm peeing a lot, and I'm tired. Connect the dot. You can see that there's a bunch of, I'll never tell you whether this patient is in the OB clinic or not. Don't expect that. That will give you the answer away. But your breast is a different location, right? Frequency and tired. That means if you draw the individual like that, the bladder is here. You're having urine frequency. The breast is here. It's what? Soreness, and the whole body is tired. You have 3 systems involved that tell you something is wrong. There's systemic manifestation. Do you ask them about when is their last menstrual period? Or do you check their leg and see if their ankles is swollen? or if you ask them if the baby is moving, or whether they have a family history of hypertension. Well, how would asking about family history of hypertension? I never give you hypertension, their vitals. So you don't know whether they are hypertensive or not. That is gone. I did not tell you the patient is pregnant. Therefore, you can't ask if the baby is moving. Well, it's okay to ask for the ankle is swollen, but what information would you give you? I've given you 3 signs and symptoms. Connected that. This look like somebody who is pregnant, and therefore ask for menstrual period. That is the content here. This constellation of symptoms is consistent with what? Pregnancy. Symptoms suggest early pregnancy. So find when their last menstrual period, and that will help you. 22 weeks, second trimester, gestation. Make the following statement. Which one require follow-up? You have a bunch of them. 4 patients. They are all 22 weeks. What do you think? I feel the baby move every day. What do you think? I have mild heartburn after large meal. I have lower abdominal cramps and back pain. My breasts are getting larger and sometimes leak fluid. Pregnant lady, 4 weeks, 22 weeks. Which of these complaints should make you worry? That's all. Don't make it difficult. Straightforward. I give you the answer. If it's consistent with pregnancy, ignore it. I feel the baby move every day. Good idea. I have mild heartburn after large meal. Of course, when you eat, food stay in your stomach. Because of the big uterus, it pushes on the stomach. You have heartburn, expected finding in pregnancy. If you have lower abdominal cramps and back pain, I think that's worrisome. It sounds like preterm labor. My breasts are getting larger and sometimes leak fluid. Yeah, you got to prepare milk, and your breast is going to get bigger because of estrogen production. Therefore, what do you think? Hey, we should worry about this lady going to preterm labor and therefore require evaluation. 3 is the right answer. The client is admitted with what? Severe preeclampsia. Keyword, as soon as you hear that, I need to prevent seizures. Which action is the next priority? What would you do to prevent seizures? Administer blood pressure medication as prescribed. Insert Foley to monitor urine output, right? Initiate seizure precaution, right? Give the patient magnesium sulfate. This requires some test-taking strategy and think about prioritization. I say the nurse priority, right? Priority means what would you do first, right? I know you have a problem. You have severe preeclampsia. But which 4 options, if you have to pick? Do you treat the blood pressure? Do you insert Foley, initiate seizure precaution, or give them magnesium? There's a content here. You have to pay attention. It's a prioritization. What is going to kill this patient is having seizures. And therefore, what do you want to do? Make sure when they get seizures, they're safe. Therefore, in every question, when you pick in an answer choice, safety before medication. Always safety before administering medication. Therefore, initiate seizure precaution. I know you're going to get magnesium. I'm going to give it to you. You may need your blood pressure to be controlled. Fine. But the first thing is safety first. This question requires some test-taking strategy and thinking. This is maternity nursing, NCLEX practice questions and answers to answer this question using expert rationale. But pay attention. Seizure precaution before you give the medication to the patient. And you do that all the time, but you don't pay attention. If that brings this patient to you, you make sure the bed rails are up. You make sure they are on their left side. You make sure you're giving them more instruction before you come and give them magnesium drip. You can't just come and hang magnesium drip while you have not initiated seizure precaution. Question 6. Which instruction should the nurse include for a client at what? 5 months gestation? Select or apply. What are you going to teach the patient? They should avoid exercise until the 3rd trimester. They should lay on their back to rest. They should expect glucose tolerance test to be done. They should expect fetal development check on the baby using ultrasound. And what? Iron-rich food to improve their diet. They should have iron-rich food in their diet. Of course, yes, you should have iron-rich food in your diet to prevent anemia. Glucose tolerance test is done in what? In 24 to what? 28 weeks. So that is in a right range. At 20 weeks, we do fetal development check with the ultrasound. A pregnant lady should not lay on your back after 20 weeks. So that's bad. She's 5 months. That's not good. And then she can continue to exercise as much as possible. So this is the content related to this question. Therefore, iron-rich food, getting glucose tolerance in a few weeks, and then getting ultrasound to look for fetal development. This is very important. 7 questions so far. What is your score? Put it down. Let me know. I know you have 6 out of 6, but this is glucose tolerance test. 1 over. What is your content? You have to know what it means. And then you can teach the patient. That is the key. If you know your concept, teaching, risk reduction, anything they will ask you, you know it. I should avoid eating and drinking for 8 hours before the test. Is that true? I will drink a sweet glucose solution for the test. Is that true? If my result is high, I will need 3-hour glucose test. Is that true? The test helps screen for gestational diabetes. Is that true? That is the concept. Test taking strategy. I see 1 hour glucose tolerance test, and I look for gestational diabetes. Were you pregnant? And if your glucose is high, you have gestational diabetes. Therefore, 4 sound good. I don't know what it means, gestational diabetes, but I know I'm looking for your glucose and you're pregnant. Therefore, you have gestational state, you are in a gestational state, and if you have diabetes, we combine together, we make you gestational diabetes. That's how you name it. If your result is abnormal, yes, you need 3-hour glucose tolerance test. That's the fasting one. That make number 1 wrong because you're not supposed to fast. It's a random test. If 1 is wrong, then I have to drink a sweet glucose solution for the test. That's what you need to do. Therefore, 1 need intervention because she does not understand that you don't need to fast. Just walk into the lab and then we give you the glucose test and then we check it 1 hour later. So 1 is the right answer. Which antepartum client should the nurse see first? A bunch of them. 1 is 36 weeks, 28 weeks, 32, and 30. What are they reporting? Braxton Hicks contraction, headache, and visual changes, occasional heartburn, frequent urination. If you're 20 weeks, the bladder is going to be irritated. You're going to pee all the time. 20 weeks, occasional heartburn is normal. 28 weeks, and you have headache, vision change. That's preeclampsia. 36 weeks, you're going to have what? Irregular contraction. That's Braxton Hicks contraction. Therefore, number 2 is in trouble. We have to do something. Which question should the nurse ask? What would you ask? Pregnant client report urine frequency and burning. That's not good, right? Pain and frequency look like infection. But what do you want to elicit? Whenever somebody have bladder infection, you always want to elicit whether involve the kidney. So this is the kidney. You have your 2 kidney here, and then you have the ureter that connect to the bladder. So if you have bladder infection, this is what we call cystitis. If you go to your kidney, you have pyelonephritis. I don't want pyelonephritis in a pregnant lady. Cystitis is okay, but I don't want any infection because it can cause preterm labor. Therefore, what question would you ask to see if they have pyelonephritis, fever or flank pain? Are you drinking enough water that day? Do you restrict caffeine in your diet? Have you felt fetal movement yet? All of them is not important. The most important is to see whether the frequency and urination is getting worse. Are they having infection? Do you have back pain? Do you have flank pain? Do you have fever? This tell me the infection has gone to the kidney and you have pyelonephritis. Drinking a lot of water, restricting caffeine, and feeling the fetal movement at this stage is not important because of the symptoms the patient is complaining about. Therefore, number 1 is the best answer. The first trimester client report what? Reflux at night. Last question. What do you think? Which instruction should the nurse provide? Selected apply. Look, when you see these questions, you already know this because I can tell you, you know it. This is gastroesophageal reflux. It's the same treatment you give to somebody who is not pregnant. So don't make it like a special pregnant lady should have a special reflux management. It's the same thing. What do you know about gastroesophageal reflux? Well, do you eat small frequent meal? Should you avoid laying down immediately after eating? Do you elevate your head of the bed at night? Do you take over-the-counter antacid for 4 weeks? Do you drink fluid with meal to aid digestion? What do you think? Of course, frequent small meal is much, much better, right? You should avoid laying down right away after you eat, then you reflux. You got to keep your head elevated. You cannot take antacid for 4 weeks. If you got to take it at all 2 weeks. And if you're pregnant, you got to talk to the doctor before. You should not drink with milk to aid digestion. This is going to make things worse. First concept, what do you need to know? Lochia information. This is a high yield fact you got to know. One question, I'm going to give you all the key facts. Which entry requires further teaching? A charge nurse is reviewing documentation from a novice nurse caring for 4 postpartum clients. Which entry requires further teaching? That means the novice nurse did something wrong. A documentation is inappropriate. Number 1, Lochia rural. What did she put down? Large clot noted on day 1 postpartum. Lochia. Serosa, pink brown in color on day 4 postpartum. Lochia. APGAR, creamy white discharge on day 10 of postpartum. Lochia. Rubor, bright red and clot on day 6 postpartum. What do you think? The content here is what color of Lochia do you get based on the post-op? And so this novice nurse documented something about 4 patients that need further teaching. Do you get rubor, red, on day 1 with some clot, serosa, turning into pink brown, day 4? Do you get APGAR, which is white, close to day 10, or rubor, bright red, and some cloud on day 6? What is the content? Day 1 to 3, rubor, you're supposed to see black clots, red. Serosa start close to 4 to 10, or sometimes 9 days, or 10 days. But what is the problem? Pink and brown. After that, it's supposed to turn white. And from 10 days going to multiple weeks, then it goes away. It never goes back. Whenever it returns back to different color, it has already passed. That's hemorrhage. Number 4, the rubor with the blood and clot on day 6, that's abnormal. What is the problem? The novice nurse documented something that should be basically taken care of in terms of bleeding. This is bleeding. You should not document this because these actions need to be taken as soon as possible. She just documented. These need further teaching that this patient was bleeding at that time. So what is the concept? This documentation shows the novice nurse failed to recognize abnormal lochia. You may see something like this in the NCLEX, and they're trying to trick you. It's just testing strategy, bringing the concept associated with what maternity nursing NCLEX review is what you find on that question, and then you use it to answer questions. So watch for these kind of questions where they're asking you something is wrong, but you don't see it, but it's right there. Number 2, another concept regarding vaccination. Which teaching is the nurse a priority? A client who recently received what? MMR vaccine is discussing pregnancy planning. Buzzword, go for the buzzword. Always go for your buzzwords and focus on it. So what am I going to focus on? It? MMR vaccine, I'm planning for pregnancy. And then priority. What do you tell the patient? Teaching question. You should avoid pregnancy for what? 1 month after the vaccination. 2 said, this vaccination will protect your baby against rubella in utero. You should also receive tetanus booster at this time. this vaccination can be safely given during any trimester. What do you think? You can see some of the answer choices are contradicting each other. There's taking strategy, and some of them are stating fact, but the fact may not answer the question. Look at the way I'm looking at them. You can stop the video and answer it yourself. This vaccine will protect your baby against what? Rubella in utero. Of course, yes, it's good, but it doesn't answer the question. What do you teach the patient? You should also receive a tetanus booster at this time. It does not answer the question. This vaccine can be safely given during any trimester. It's a wrong answer. This is a live vaccine. Pregnant patients should stay away from it. Even though this is going to protect your baby, this is not the most important information at this time. The nurse is supposed to tell the patient. The most important, don't get pregnant. Okay? After vaccination, this kind of vaccination, if you don't wait at all, at least 30 days. So the content here is to teach them the most important thing. And therefore, 1 to 3 months, you're supposed to wait before you get pregnant. Otherwise, your baby is going to get into trouble. So that's the number 1 is the right answer. Which client is in active phase? If you don't know anything about labor and delivery, please stop. I have a bunch of video. I will link it to this. Supposed to know all the phases of the labor. There's not a lot of them. Most of them is in stage 1. And if you know them, that's where most of the actions will occur. They always like stage 1 and all the phases within the stage. Which client is in active phase? The way to answer this question is to know that stage 1 is divided into 3. And if this is divided into 3, then 1, 2, 3 have latent phase, active phase, and then transition phase. And you have 100%, you have to be at the transition phase. Therefore, this has to be 30. This has to be at least 60. And then this will be 70 to what? 100, right? Therefore, contraction or effacement has to be like 1 to 3. This to be close to like 4 to 7. You see what I'm doing? And I'm using that to see how I can arrange it as what? This is an active phase. To be in the active phase, 2 centimeter dilated is still in the latent phase, right? 5 centimeter look like is in the active phase. 9, you close to the transition phase. I told you, divided this into 3. You can see from 1 to 3, 4 to 7, 8 to 10 will be the transition phase. Therefore, this is not. And this is what? Abnormal. It's not part of the phases of the stage 1. Therefore, number 3 is the best answer choice that you can pick. You can also use the contraction. How far is the contraction? How far apart, right? And it's between 3 and 4. And therefore, I'm picking number 2. And so this is what is giving you. Active phase is 4 to 7 centimeter dilated. Contraction has to be 3 to 5 minutes. And there is moderate to contraction. Which fetal heart pattern is most concerning for fetal hemolysis due to what? RH incompatibility. This one, please know it in case you see it. It's a very important fact you're supposed to know so that in case they ask you, which fetal heart rate pattern, when fetal has so much blood loss due to hemolysis associated with RH incompatibility, you will see it on the fetal monitoring. Is it bradycardia? Is it tachycardia? Is sinusoidal pattern and variable decel? You can see, you can use the strategy. When you look at VCHOP-MI, there's only a few things that are involved, right? VCHOP-MI, right? You know, you have variable deceleration in it. This has nothing to do with what? Most of it is deceleration, not fetal hemolysis. Bradycardia is a deceleration, so it'll be one of these. Tachycardia can give you, if you have fetal hemolysis, you have anemia, severe anemia. But tachycardia can be infection, it can be anything else that can give you. So it's not specific. So the word most, you can see, is associated with sinusoidal pattern. Sinusoidal pattern, the fetal monitor look like that, smooth. Instead of going like this on normal fetal heart This one is very, very smooth, like a musical tone. And that is worrisome, associated with what? Fetal hemolysis. And that is number 3. So watch for that. Sinusoidal pattern is pathological associated with severe anemia. And this is 3 is the right answer. A client at 33 weeks gestation is admitted with what? Preterm labor. Which intervention should the nurse expect? Select or apply. 5 questions. What is your score? Number 4, I want you to stop the video, answer this question, put your answers in the comment, and then I will take a look at it. I will comment on it. But if you reach this here, number 5 question, stop the video, put down your answer, and answer it, and let me see. Because these are data in class. We're doing this together. We're learning this together. Stop your video, put down your answer. But what do you think? Concept, preterm labor. What intervention should the nurse expect? Test-taking strategy, preterm labor. Write it down, preterm labor. Which intervention should the nurse expect? Select or apply. Underline the buzzword, preterm labor. What is your job? Job is to stop labor from progressing. So whatever answer choice you're going to pick, I need to prevent labor from progressing. Give them tocolytic. Is it going to stop it? Give them opiate. Is it going to do that? Give them IV steroid. Is it going to do that? Monitoring fetal heart rate. Prepare for immediate induction. Prepare for amniotomy. And administer prescribed antibiotic. Like I said, put down your answer. Let me know what is your score. But this is the content you're supposed to know. When you are in preterm labor, we got to anticipate that you're going to have prolonged labor. Therefore, antibiotics is needed to prevent infection. I don't want you to deliver, so I'm not going to break your memory. So this is wrong. You should not prepare for induction unless there's severe. We don't want to do that. The kid is 33 weeks. It's not ready yet. We should monitor the fetal heart rate and contraction. Steroid is given as IM. This is wrong. Opioid is never part of the preterm labor medications. If you give it to them, sometimes it can affect the kid, causes bradycardia, and we will prescribe tocolytic. So these are what is needed in preterm labor, and I want you to write it down. Antibiotic, tocolytic, resting steroid. Those are the key things you have to pay attention to. Which client order for IV opioid should the next question? I'm following based on that. Like I said, this is our concept. Concept. For patients, they've been prescribed opioid. They are in labor. Which one should you question? The client is 3 centimeters. It dilated with regular contraction. 6 centimeters, dilated in active phase. Is in transition phase at 9 centimeters dilated. In the latent phase at 2 centimeters dilated. What is the content? Once again, what is the content? You only give opioid most of the time at the active phase. You should never give it at the transition phase. If you give them during the transition phase, the baby will get it. And because after transition phase, baby will be delivered right away and it can cause respiratory depression. Therefore, give it the most during active phase. You can give it at latent phase, but the most important is at the active phase. So which one? The next you question, number 3, we need to question 9 centimeters, you are in active phase. But like I say, if you need to know the phases of the labor, I will link the video, and I will link the video attached to this. Check the description, and you'll be able to answer any question regarding labor and contraction. Before administering IV opioid for a pain relief to a client in active labor, the nurse should what? This is all based together. Like I said, these are little concepts. If you have it, you master maternity. You just break it down, whatever question they will give you. If you watch all these series, what is the problem? I said, before giving opioid to a client, what should you check? Their memory is ruptured, whether the contraction is at the peak, whether the cervix is dilated, and then what? Effacement and 100%. You got to measure the what? Cervical dilation. You ensure effacement is 100%. You ensure the memory is ruptured. you ensure contraction at the peak. The nurse should make sure before they give the opiate, okay? I'm pretty sure you check everything. You measure the cervical dilation. You know the effects. First, the effacement of 100% is completely wrong. 100% means you're in transition phase, so you cannot use it. If memory is ruptured, of course, it doesn't change anything. What will change something is related to the cervical dilation. But the most important, if you have to give it, you got to make sure you're giving it at a peak of contraction so that the baby does not get it. So number 2 is the best. Painless uterine contraction that occur throughout pregnancy is known as what? Is it through labor, precipitous labor, Boston Hicks contraction, hypotonic contraction? I know these are bonus answer, bonus question for you. And I know you got it because you get 8 out of 10. It's right there, number 3. And this is prioritizing care for maternity client, prioritization, patient prioritization, increase what? Priority regarding maternity patient. A client with diastolic murmur at 28 weeks of gestation. A postpartum client in the letting in phase. A client in latent labor requesting pain medication. A client at 32 weeks reporting occasional malcontraction. Who do you want to see first? Who do you think we should see? Maternity patient. Prioritization 101. Occasional contraction is fine, 32 weeks, Boston Hicks, probably. Latent labor requesting pain medication. Yeah, you can give it to them. We have time. Postpartum client in letting in. What do you think is the letting in phase? We'll talk about it. There's a question there. But diastolic murmur in the patient is 38 weeks, that's a problem. It indicates cardiac problem. It's not preeclampsia. Watch this. Write this down. Diastolic murmur in a pregnant patient is a cardiac problem. A systolic murmur is suspected, but a diastolic murmur is a weak problem. It's really indicate cardiac dysfunction. So you should watch for that. Don't forget this concept. Systolic murmur is fine, but diastolic murmur that you hear in a pregnant lady, worry about cardiac dysfunction. I know you get 9 out of 9. And the 10th one, put this on the cherry and get me 10 out of 10. Adapt NCLEX, Maternity NCLEX review. Which nursing action is appropriate for a client in letting in phase of postpartum adjustment? This is a little bit hard, but you have to know there's 3 phases here. After delivery, we have letting in, letting out, and letting go. These phases are very important. You need to know what occurs each stage, right? In letting in the first few 1 to 3 days, the mommy is all about themselves. They're selfish, but that is fine. They care about themselves. They talk about themselves. They talk about how they go through the labor. Everything is about them. Just help them. In letting out is then they try to learn about the baby, what is going on with the baby. They're ready to, you can teach them about the baby. And then letting go, they are in full control. So encourage socialization with other new mommies. That's not the first stage, which is usually the last stage. Teaching about contraception is also the last stage. It's irrelevant. Promoting independence with a newborn, that is what? Letting out. Basically, now they want to know about the baby. Encourage the client to rest and process birth experience. That is what? Letting in is about themselves. Each of these questions contain a concept, and one concept is what I'm going to test you. This requires some critical thinking and prioritization, patient prioritization. Which statement should the nurse be most concerned about? A nurse is returning phone call to several clients 6 days postpartum. Which client statement should be concerning to you? My hands feel numb after holding the baby for a while. My peripad contained dark red blood. I still had bright red blood in it. I have been more emotional and cry easily. Which of these patients should you worry about? Stop the video, answer the question, put down your answer, and let me know what you think. But based on the content, after delivery, there's a fluid shift. It's common to have something we call carpal tunnel syndrome. So your hands should feel numb after holding the baby for a while. It's expected.
A peripad containing dark red blood is unexpected because it's 6 days. After 4 days, you should not have Lochia ruba. Therefore, this lady, she's bleeding. 6 days is a problem. My stool had bright red blood in it. This is called what? Hemorrhage. She probably had hemorrhage. I'll be more emotional and easily what? Crying. What is the problem? This is postpartum blue. And you can see based on that, number 2 is the right answer. A dark red is rubra. Should be gone by what? Day 4. And therefore, number 2 is our right answer. We're going to use this content, this strategy to answer each question. A nurse is teaching a postpartum client about what? Breastfeeding. What am I going to teach you here? Breastfeeding. If you have not seen a video about it, writing that concept. If you're in nursing school, no breastfeeding. And for the NCLEX, no breastfeeding. What are the things they're going to ask you? Which statement by the client indicate a correct understanding of the teaching? Most of the question, it will be about what? Teaching, teaching, teaching. And therefore, watch what I'm going to do. Select or apply. We want to indicate, pick a correct understanding. I should bring my baby to my breast when they show early hunger cues. Is that what you do when you want to breastfeed your baby? For the NCLEX and nursing school, I should feed my baby on a strict 3-hour schedule. Is that what you want to do? Every 3 hours, feed the baby. I will allow my baby to finish feeding on one breast before switching to the other breast. I will wash my nipples with what? Soap before and after every feeding. I should expect my baby to have at least 6 to 8 wet diapers. There's a content here, and I'm going to give it to you, and I want you to write them down. Every time they ask you questions about breast and breast teaching, feeding, this is the way they're going to ask you. You feed on demand. That's the cue. Feed on demand, right? You don't feed every 3 hours. Therefore, 1 and 2 are contradicting each other. Therefore, 2 is wrong. I will allow my baby to finish feeding on one breast before switching to another. Yes, because you want your baby to get the fore milk and the hind milk. That's where you get most of the antibody. The end of it is the most important. I will wash my nipples with soap before and after every feeding. No, soap on the nipple is going to make it dry and you get sickness from it. You get infection from it. What you need to do, warm water. I should expect my baby to have at least 6 to 8 wet diapers daily. That is good. It means hydration after breast milk. And therefore, what are our answer? Number 1, feed on a cue, not on demand. Switch from one breast to another after they finish it completely. We have another question. I will show you how many times you're supposed to feed on each breast. And you want to stick around to watch that one. As we go with the video, the question get harder and harder and more concept. And you want to get to them. And there will be second part associated with this video. And therefore, those are the right answer. No soap. And nurse is assessing several postpartum client 12 hours after vaginal delivery. They just deliver 12 hours. Which client need immediate intervention? This also is based on concept about what you look for when they are postpartum. It's talking about bleeding, postpartum hemorrhage, which is associated with their part, what we call Lochia. If you saturating a peripad every 30 minutes, should you be worried about? 12 hours. Saturating a peripad every hour, should you be worried about? Saturating more than 1 peripad in an hour, saturating 2 peripad in 2 to 3 hours, saturating 1 peripad in 2 to 3 hours, passing cloth larger than a golf ball. I designed this question to test your mind. I want to give you every angle so that whenever they ask you a question regarding a peripad, you are in strong position to answer it. What do you think is the concept? Try this one and let me know what you did. Stop the video, put the answer in the comment section and let me know. But there's a content associated with what? Answering this question. And it's 3 words. And this is it. If you saturating a peripad less than an hour or an hour, you are in trouble. Therefore, 30 minutes is less than an hour, 20 minutes less than an hour, 50 minutes less than an hour, or equal to an hour. That's the first one. If you're saturating more than one part within an hour, it's also a problem. You got to write this down. And if you pass in large clot greater than a golf ball, it's still a problem. These are the three conditions you need to know about somebody with the peripad when you see a question. Therefore, if you saturate more than one peripad in 1 hour, that means 2 peripad in an hour, you're in trouble. Even I give you a scenario, if you saturate 1 peripad in an hour is a problem, therefore 2 peripad, that means more than 1 is a problem too. If you're saturating less than 1 hour, that means every 30 minutes you are in trouble too. And if you're saturating peripad every hour, that is the original condition, that is a problem. And of course, if the clots are larger, more than the golf ball, that is bleeding. Saturating 2 peripad in 2 to 3 hours, if you calculate it, 2 to 3 hours, that means the average, okay, when you saturate 2 peripad is about 1 hour and 30 minutes. That's okay. And if you saturating peripad, 1 peripad in 2 to 3 hours, that means it's also more than an hour. So that is good. So 4 and 5 are not the problem. They are moderate, but they are not severe. They don't indicate excessive hemorrhage at 12 hours. So that is the content. A nurse is caring for several postpartum clients, breastfeeding their baby. This is part 2 of what we saw. Which client need further teaching? We already know about breastfeeding. Now I'm going into deeper, giving you more content regarding breastfeeding. And those 2 questions should be your friend. There's a third one you want to stick around. The client is breastfeeding the baby 8 to 12 times per day. Is this what you should do? 8 to 12 times per day, feeding the baby? Client breastfeed the baby when the baby starts suckling. Is this what you should do? You should give the breast milk as soon as they start suckling. Client position the baby tummy to tummy. Is that the position okay? Client breastfeed for at least how long? 18 to 20 minutes per breast. Each breast is being fed or used 18 to 20 minutes for the baby. And feeding for 8 to 12 times per day, multiple times, which is equivalent to 2 to 3 hours. Client offer same breast each time. So who need a further teaching? Who need further teaching? Yes, you're supposed to breastfeed 8 to 12 times per day. If you calculate 24 divided by 12, that means at least every 2 hours. So 2 to 3 hours, you should be feeding the baby. And you should give them on demand. So when they start suckling, you should give it to them. It has to be tummy to tummy. And each breath, at least if you don't give it to 18 to 20 minutes per breast, you should offer different breasts all the time. These allow the breast not to engorge. These allow them to get all the feeding they need as much as possible. And this prevent infection. So the only answer choice is number 5. And this is caring for a client 5 days postpartum. Which statement indicate the client is in taking hold phase? There is 3 phases associated with postpartum. You have to know. I talked about it in the previous video. The first one is letting in, which is what? Let me write it down. The first one is letting in. And the second one is what? Letting out, which is what? Holding. That is taking hold. And the third one is letting go. Each of them has a concept associated with it. And I'm going to give it to you. It's good to know them because that's the way the question is based on, if you know them. So what does that mean to taking hold, which is the same thing as letting out? I need to rest. I can't focus on the baby right now. I want to try changing the diaper myself. I feel sad that I cannot care for the baby perfectly. My partner will take care of the baby until I recover. What does that mean, taking hold? It means what? Letting out. And the key is you are caring for the baby. You start to care for the baby. And this is the content. The first stage is letting in. That means you start talking about yourself. Then letting out, which is what? Taking hold is about the baby. You want to learn about the baby, things about the baby. And letting go is you adjusting to the situation now that you have a baby. So which statement indicate letting out? That means you want to care for the baby. I need to rest. I can't focus on the baby right now. That is letting in about yourself. I want to try changing the diaper myself. I want to learn about the baby. That's the baby. I feel sad that I can't care for the baby perfectly. This is about you. My partner can take care of baby until I recover. Still, basically talking about you. You want to take your rest. Therefore, number 2 is your right answer. And then it's assessing a client who is 2 days postpartum, 2 days. Which finding require intervention? What do you think after 2 days? One said the fundus is firm, 3 centimeters below the umbilicus. 2 said fundus is firm, 2 centimeters below the umbilicus. 3 said fundus is boggy and deviated to the right. 4 said fundus midline and firm. What do you think? I know you got it because you watch Adapted class, and this question is straightforward. Don't think I'm tricking you. This is it. This is it. You know the content. As postpartum, the fundus is supposed to go down. So far as it's below the umbilicus, I'm good. It should be firm. So far as it's firm, I'm good. That's all. Therefore, 1 said firm is below the umbilicus, even though 3 centimeters usually is supposed to be 2 centimeters, but it has gone down more. It's a good thing. 2 is the most appropriate. 2 centimeters each day has gone down, but 1 and 2 are saying the same thing. The uterus is going down and is firm. If you go down faster, it's good. Fundus is boggy and deviated. It's not firm, and it's dilated and it's deviated. Bad problem. Number 3 is your right answer. And then she's teaching a breastfeeding client about mastitis prevention. This is the last question on breast, and you should be comfortable answering any question regarding breastfeeding and teaching. Which statement indicate understanding? I want to prevent mastitis infection. I should stop breastfeeding on the affected side. Is that possible? I will wash my nipples with soap after every feeding. We talk about it. I should alternate breast with each feeding, right? I will apply tight bra to decrease engorgement. If I want to breastfeed to prevent infection, there should be no engorgement, right? If you use tight bra, you cause more engorgement. For its bad statement. Alternating the breast is the best way so that each breast gets emptied every time to prevent engorgement. I will wash my nipples with soap after every feeding. It causes cracks and nipple dryness. I should stop breastfeeding on the affected side. You should feed even when that area is affected. Therefore, 3 is the best answer. And let's evaluate a client 1 week postpartum who report what? Tearfulness, fatigue, feeling overwhelmed, but denying suicide. There's a reason why there's a word deny, suicide, and it's 1 week early postpartum. Feel tired, tearfulness, right? Feeling overwhelmed. That means irritable, like emotionally, right? Very sensitive. What do you want to do? Refer them to psych, reassure this is postpartum and it's common, and monitor them. They should stop breastfeeding right away. Give them antidepressant. Look at it. It's either blue or depression or psychosis. Psychosis, they have hallucination. There's no psychosis. There's no depression because what? Patient is not suicidal. They are not hopeless. They just tearful, emotionally labor. This is what we call postpartum blue. Reassure them. 9, and then care for a client after what? C-section. I know you got it. Adapted class got you. And you see the concept. I'm using each concept to answer the question. I want you to write them down. You stop the video and then write all the concept and watch the video, answer the question. You see where I go for the content and how I approach each question. Test taking strategy, NCLEX practice question, right? Maternity nursing, NCLEX review. We're using aspect analysis, explaining in detail the rationale associated with each answer and the wrong answer. And you do that and you get the content right there. How can you prevent thrombophlebitis like a DVT? It's not a true DVT, but early form of it. And next care for a client after C-section. Which intervention help prevent thrombophlebitis? Let them walk, restrict fluid for 24 hours, apply compression stocking, and massage the leg. Let me know which answer choice you pick for this, because this is very good test-taking strategy, critical thinking. Think about the answer choice critically. Walking, compression stocking, restricting fluid, and massaging the leg. Massaging the leg does not help. Restricting fluid will worsen it. Now you're left with what? Encourage ambulation and compression. I would rather walk like than you putting something on my leg and squeezing all the time. Walking is the best way to prevent DVT, thrombophlebitis, than medication. Therefore, the best thing to do is what? Let the patient walk rather than compression. And the answer choice is encouraging ambulation, promote venous return, prevent blood stasis, reduces the risk of what? Thrombophlebitis. And this is the concept associated with that question. And that is the best answer. Walking. Last one. I know you get 9 out of 9. Now I want you to get 10 out of 10. And this is a concept this is a concept you should know regarding postpartum hemorrhage. I'm giving you the content. Write them down. Which of these patients has a highest risk of postpartum hemorrhage? Who? Prolonged labor, microsomic infant, uterine atony, infant that is greater than 4,000 grams or 18 pounds and 12 ounces, or if you have a twin baby or chronic amniotitis. There's the content associated with postpartum hemorrhage. This is what we call risk factors for postpartum hemorrhage. Content is what? All of them are right. Anything that will make the uterus bigger, anything that will slow down the uterus is a problem. Prolonged labor, the uterus get tired. It doesn't contract easily. You bleeding. Microsomic baby is big. And what is that? It's the same as what? 4,000 grams, 18 pounds, to 13 ounces. I'm trying to let you know what does that mean to have microsomic. If they don't give you anything greater than 4,000 grams, is microsomic. Anything 18 pounds and 13 ounces is microsomic. If you have twin baby, multiple gestation, you're going to have postpartum hemorrhage. Chronic amniotitis. Infection will cause the uterus not to contract, and that can cause bleeding. Therefore, all of them are right answers. All of them, these are right answers. So write them down. Risk factors for postpartum hemorrhage. 10 questions. Critical thinking. High-yield question. NCLEX practice questions with answers. In this rational maternity nursing. We're talking about postpartum care. Thank you for watching and good luck.